Everyone, on behalf of MESDA, I would like to say a few words at the opening of this course as the chairman of MESDA. Welcome to our MESDA webinar, Minibari in Surgery for Rectal Cancer today. MESDA has been conducting the training course since we established in 2016 due to their all member activities, and we reached to this 17th workshop of July. This time, we hold ad hoc online events separate from our continuing workshop. I'd like to say thank you to the course director, Associate Professor Pawat Sutarat, and international faculties, Professor Masaaki Ito from Japan, and the local faculties from Thailand for joining us today. I'm so grateful and proud that there have been so many young surgeons were trained so far, more than 600 trainees from Mekong regions such as Cambodia, Laos, Myanmar, Thailand, and Vietnam in the field of endoscopy surgery with the various areas. I hope we all can learn a lot from the expert of minimal surgery, rectal cancer surgery, and obtain new knowledges and skills from them. Okay, let's start it. Thank you, everyone.
Thank you very much, Professor Kitano. Okay, let's our vice president. Okay, we will go to the first topics. The first speaker, Professor Masaaki Ito. He is a famous colorectal surgeon in Japan and also in Thailand too. So he is the head of Department of Colorectal Surgery Division in National Cancer Center is in Tokyo, Japan. And he also today he will give us very special lectures about the update of TATME. Professor Masaaki Ito, please.
Yes, thank you very much for inviting me this very great meeting for all of my friends in Thailand. So Pawit, thank you. And also, I am really thanks to the leader of Professor Bitun and the Professor Kitano Sensei. So, and also the all Thailand colleague. So I miss you. So how are you doing now? So in recent current status in Japan is patient of COVID-19 is a little bit decreasing now after Olympic finished. So today, so I'd like to talk about the update of TATME. I'd like to show the recent research of mine. So I switch to this slide. Can you see my slides? Okay.
Yes. Yes.
Okay. Thank you very much. So at the beginning of my talk, I'd like to show the TATME figure like this. So I love TATME procedure since 2013. So I have the 8 to 9 years experience of TATME. So one of the greatest merit is we can see a whole area of the pelvic space from below, and also straight dissection is we could perform by the straight dissection. So no needs using multi-joint forceps like a Da Vinci system. So very convenient and very comfortable procedure for us. So there are some candidate of the strategy for surgical option for rectal cancer. There are 3 options: LAP, robot, and TATME. So I think the lab and the robot is a very similar approach from above. TATME is entirely different concept, so from below. So different between the lab and the robot is the devices. Lab has very straight devices. Robot has articulated devices. So view from below is entirely different with the TATME. So why we love TATME? What are potential advantage in performing the TATME is, so TATME has improved visualization from below, easy access to rectum, aids better quality TME, accurate distal margin. This is a very reliable advantage. And later, I will show this benefit of anastomosis. Safe anastomosis was produced by avoiding dog ear and multiple firing, and two-team procedure could provide us drastic reduction by two-team approach. Or you know that this is a very famous paper about the TATME of the registry data included in 720 cases. This registration data shows that R0 resection is very high, and only 22.4% of positive CRM was preserved in this trial. So at that time, we think this approach could reduce the positive CRM in rectal cancer treatment. However, 2 years ago, so from Norway, very bad news was brought to ours about the TATME has very high local recurrence rate of 11% compared to the usual TME procedure had 2.4%. And also the anastomotic leakage rate is 8.4% in TATME compared with 4.5% in TME procedure. So at that time, we getting this bad news from Norway. So all over the world, colorectal doctors had a very opposite feeling to the TATME at that time. But this is from the Dutch. So about the long-term oncological result after TATME for rectal carcinoma. This report has conducted by the two-center study. So more than 100 cases and very good local recurrence rate of 2.0% at 3 years and 4% and 5 years. And also another report has we could get the outcome from multi-center cohort study. So this study also showed a very good local recurrence rate of 3% at 2 years, 4% at 3 years. So this study shows a good local regional control after TATME if the procedure was performed in a selected cases from the very large center with a very higher scale. So what went wrong in Norway? Maybe we could point out the 3 points, 3 clinical issues. First is Norway did not select correctly the patient in performing the TATME. So through their paper, among 20 patients with recurrent cases, only 1 received neoadjuvant treatment, despite 8% patients having the stage 3 and the stage 2 disease. And also, most important thing is they have very low case volume. So 3 center abandoned TATME after just 5 cases, and the other 4 averaged less than 10 TATME cases per year. And also the inadequate preparation was pointed out. So I think that to avoid such a disaster in the performing the TATME, so most important thing before starting TATME, first is to get pursuing suture technique from below to avoid cancer dissemination during the TATME procedure. And also second is to understand unfamiliar surgical anatomy from below. So I think the left figure is a very perfect pursuing suture. Very beautiful, very even pursuing suture was observed in the left figure. And oppositely, the right figure shows the very ugly feature after pursuing suture. So I think the very even and very beautiful pursuing suture is very important to avoid such a disaster in terms of local recurrence. So we need to train that transanal pursuing suture. So this is we innovated such a training, dry training box in terms of the distal pursuing suture in Japan. And also that I would like to insist on the importance of understanding anatomy from below. So repeatedly, I told you the importance of recognition of longitudinal muscle fiber all around the rectum. So 0 o'clock and 6 o'clock is a little bit thicker longitudinal muscle fiber is observed, like rectal urethral muscle and the rectal coccygeal muscle. In anterior side, so usually we felt a very difficult feeling in dissecting anterior side of the rectum, but TATME, we could see very clearly recognize longitudinal muscle fiber of rectal urethral muscle. This distance is about 5 to 6 millimeter, so that we could control the dissection line depend on the T stage. And also the posterior side of the lateral side. So we also change the surgical plane to secure in our CRM. So if the tumor is advanced side, we can dissect below the endometric fascia. So this is T3 cases, tumor located in the posterior side. So in such a cases, sometimes positive CRM was observed. So these cases have some risk of positive CRM, but in TATME procedure provide a little bit deep dissection procedure like this. So now CALA 3 trials ongoing now. So actually our institute is joining this CALA 3 trial. So included the patient is about half of the planned patient. Now about maybe 600 or 700 patients already included in CALA 3 trial. Maybe 1 or 2 years has passed, this CALA 3 trial is completed. So this complication, next we move to the complication. So first important complication is CO2 embolization. So to tell the truth, so I experienced more than maybe 20 cases, more than 20 cases I experienced already. So most important thing is we should identify the whole of injury site, usually the very small hole of vein. So if we did not aware of such a injury for the vein, so a patient vital sign is go to bad status. So I'd like to show the short video. So this is the neurovascular bundle area. So you could see, very small video. You could see the small hole in a vein of the neurovascular bundle area. So insufflation is by the saturation of 15 to 20 milli Hg. So we did not see any bleeding. But if we stop the insufflation, maybe the bleeding was observed from this hole of the vein. So we need to identify such an injury for the vein quickly. And next very important complication is urethral injury. So this very famous paper of the Patricia Schiller clearly showed that this very major complication is strongly associated with lack of experience. So the less than 8 experience is very strongly associated with such a urethral injury. So to avoid such an injury, so we sometimes use the lightning catheter. We inserted from the urethra, so that we change the using fluorescein scope clearly shows the lightning. So we identify the existence of the urethra like this. So we could identify this is lesion of urethra. So this lightning catheter is very helpful for us during a TATME to avoid such a complication. So actually, in Japan, we are collecting the very huge number of the video of laparoscopic surgery. So we are collecting the database of the video, and information was collected, and AI, artificial intelligence, is learning the very many annotation data. So this is one of the results of the database in Japan. So this is to avoid the urethral injury, urethra, and also the prostate. So left is the main monitor, right is the sub-monitor. So during surgery, we real-time recognition of the such prostate or urethra was completed using such an innovative system like this. And next, move to the anastomotic leakage. So this report included in more than 1,000 cases from the registry data. Anastomotic leakage rate is about 10% of the cases. So I think a little bit high. So, and also the large tumor in obese, diabetics, male patient who smoke has highest risk of the anastomotic failure. And as for our department, to prevent anastomotic leakage, so we utilize indocyanine fluorescein angiography since 2016, and also staple anastomosis with reinforced suture was started from 2018. So in TATME, we need to close the distal part of the rectum. So we usually perform single stapling technique followed by TATME procedure. Following TATME procedure like this. So we close perfectly by using this procedure and place small size catheter like this and tightening. So recently the size of the catheter is 14 to 16 French is best. So this catheter guide the devices from below, and abdominal team could identify the devices like this. So next, followed by the docking from abdominal team like this. So So this procedure provides us no multiple firing and no dog ear like this. And after that, so we change the position of the hooking of Lone Star retractor like this to move the anosmotic line to the anal side to make the Hans anastomosis easier. So by changing the anosmotic side to the anal side, so we could make the Hans anastomosis very comfortably like this. So I mostly performed Hansen reinforced suture on the stapler line was performed for the most of the cases in TAT-ME. So this procedure provides the very tightness is stronger like this. So data after single stepping technique followed by Hans anastomosis from our institute, early anastomotic leakage is only 1.8% compared to the 8.4% in Hansen group. So a very anastomotic leak reduced with the staple with Hansen anastomosis. Also, pelvic abscess and anastomotic stenosis is also less. And overall anastomotic complication is drastically less compared to the usual Hans anastomosis in a very low rectal cases, 5 centimeter within anal verge. So I think double purse string anastomosis like this shows no dog ear, no multiple firing, no need for distal mobilization of the rectum. And also, finally, the leakage rate has reducing in our institute. So another potential merit in TAT-ME is better recognition of the autonomic nerve system from below. So neurovascular bundle and the pelvic plexus and the pelvic splanchnic nerve is exists in the same layer of the prehypogastric nerve fascia. So neurovascular bundle is very clearly recognized from below, like left figure. And also third or fourth sacral nerve is also recognized like right figure. So this is our recent report in terms of the urinary function after TAT-ME. So we could recognize the amount of the resection range of the autonomic nerve system from below. So pattern A is completely preserved of the autonomic nerve system. So the type B, pattern B, pattern C, and the pattern D is gradually the resected range is bigger. So if we we recognize whole autonomic nerve was preserved from below, so urinary dysfunction is very few. So 3.8% in after 1 month post-operatively. So this data is about the half of the robotic system. So usual robotics paper shows 5 to 10% of the urinary dysfunction in 1 month post-operatively. And also lab shows included 15 to 20% of the cases is go to the urinary dysfunction. So this data potentially shows the TAT-ME could reduce the urinary dysfunction. So we could see the fourth sacral nerve like this. And also another merit is we could identify the entrance to the lateral space. So this is our cases. Very interesting case. The patient had very strong caution of the lateral lymph node dissection. So this case received preoperative chemoradiotherapy, and also perform TME plus lateral lymph node dissection following CRT. However, so 5 months after surgery, we could see the very small lymph node, and this lymph nodes grow bigger in 10 months. And after that, 1 year after surgery, we could recognize recurrent tumor. Maybe that this is a luminant lymph node in lateral lymph node area, maybe around the inferior vesicular artery. So we have, I think, the two messages. Lymph node less than 5 millimeters sometimes resulted in lateral local recurrence, and the lateral local recurrence could be observed after lateral pelvic node dissection. So maybe from my experience, this area, the bottom of the pelvis, is very dangerous. Sometimes lymph node around the inferior vesicular artery is sometimes very dangerous. Sometimes we could not resect from above because this is a very deep pelvic area, and we could sometimes some lymph nodes remain even if we perform the lateral lymph node dissection. So we started the transanal lateral lymph node dissection. We are showing the video. So this is a very good merit in deepest area of the pelvic space. So firstly, that we identify the obturate vessel like this, and after that we back to the bottom of the pelvis. So this area is very important area. So sometimes abdominal procedure could not resect this fat because of the very deep and sometimes not approaching from above. So you could see that this lymph node is along the inferior vesicle vessels like this. So sometimes this remnant lymph node resulted in local recurrence after even if we perform the lateral lymph node dissection. So also anterior side, this is a TPE prostatectomy was added for the patient. The patient has a very aggressive disease. Rectal was very close to the prostate. So I now dissecting the around the urethra. So approaching to the urethra, and we could see the catheter, urethral catheter was observed. So removing the catheter, and we would like to dissect the urethra wall all around, and remaining DVC is sometimes we met big bleeding in this area. So to avoid the disaster of the bleeding, so we sometimes we always inserted such a linear cutter devices from below. So this direction of insertion of linear cutter is very suitable from below, and the cutting provide no bleeding procedure like this. And also, this is a case of the advanced case in female. Rectal tumor is embedded to the vagina. So we could see the invaded lesion from below like this. So enough margin was kept in this procedure, and dissecting the vaginal wall. And also the closure of vagina is comfortable from below like this. So in the posterior side, So this is a recurrent cases. So recurrent tumor is observed on the cellular bone, and we perform a CRT first. So after CRT, a very small resection margin, but this area is about the first cellular level. So we could not resect the whole cellular bone. So we dissect the surface of cellular bone. So this is a recurrent area, and TATME provide a little bit deeper dissection plane, and to approaching to the tumor area. So we strictly dissect on the surface of cellular bone like this. We try to keep the resection margin for the recurrent cases. So we are burning and dissecting the exposing the surface of bone like this. So actually, we keep the pathological good margin was kept by such a procedure from below. And in the huge tumor, sometimes in such a very huge gist is also the very good candidate to perform a two teams procedure. So this big gist is we usually select initially the deep plane like this, so below the endopelvic fascia, to dissect along the levator inner muscle, and opposite side of the tumor we selected the usual TME plane. So depend on the tumor site, we change the dissection plane. So tumor is located in left side. So in this area, we dissect a little bit the deep plane to expose the levator inner muscle like this. So we can see the tumor, and finally we preserve the anal preservation was successfully done, even if such a very huge gist. So current our strategy of our institute is most of high tumor was performed with laparoscopy. So other middle tumor, low tumor, and obese patient was performed with TATME with two teams TATME with two teams procedure, LAP and TATME. And a very difficult case, like the T4 case or recurrent case, we perform also two teams, but the open and the LAP, open and TATME. This is our current strategy. So I love such a two teams procedure because very drastically operating time is reducing. So average our TME operating time is about 2 hours and a half. So, and the combination procedure by two teams provided us greatly facilitating completion of the TME and double checking of the nerve preservation enough CRM by two directions. However, so most important problem is too many doctor was needed in perform this procedure. So in our institute, so we are innovating the surgical robotic system, replacing the scopist and assistant in the abdominal team, and also the scopist in anal team. So this robotic system is surgeon can control the robotic arms in patient side and semi-automatic system equipped, and one scope and the two arms equipped in the robotic system, and the cost benefit is included. So mostly this robotic was completed already. So now we are applying to the government to permit to use in Japan in end of 2021. This company name is A-Traction. This company is in our institute. But this company of A-Traction was acquired by the big company, Asahi Intech, in March this year. So this is a promotion video of this robotic system. So this is a final production of this system. This name is another answer, meaning of another surgeon. So this arm has articulated joint like this. So if this robotic systems will go to market maybe next year, maybe 2 teams procedure. There are 2 surgeons could perform 2 teams procedure with this robotic system. So in conclusion of my talk, TATME is technically feasible, but some oncological outcome is not still clear. So the technique is associated with some specific complication, such as high anastomotic leakage, urethral injury, or intraoperative tumor spillage. So such a novel disaster is very strongly associated with the intraoperative tumor spillage by the lack of the parsing suture, pass-string suture technique. And oppositely, the single stapling anastomosis plus hand-sewn reinforced suture following TME could reduce anastomotic leakage rate. So data was shown in our institute. And we could recognize autonomic nervous system from below better than from above, which leads a better postoperative urinary function. TATME can safer apply for the complicated colorectal tumor, such as lateral node positive patient, recurrent cases, or huge tumor cases. And our current robotic system can solve the current problem of 2-team surgery requiring 5 surgeons. Thank you very much for your attention.
Well, thank you very much, Professor. It was very nice lectures. So we will keep the question in the last session. So we will go on to another speaker. That's by introduction by Professor Attapon.
Thank you very much. The next speaker is Professor Supakit Komvilai. He is our famous surgical endoscopist, especially in the field of colorectal surgery. Now he is currently head of surgical endoscopy colorectal divisions, Department of Surgery, King Chulalongkorn Memorial Hospital. Please welcome Professor Supakit.
Thank you for your kind introduction. I start with my sharing of my slide. Did you see my slide?
Yes.
Yes.
You see it.
So, okay. Good afternoon, ladies and gentlemen. I would like to thank you, the organizing committee, to give me the opportunity to share my experience today. And I am Dr. Supakit Komvilai from Surgical Endoscopy, Chulalongkorn Hospital, Bangkok, Thailand. This is my hospital in the center of Bangkok, the capital of Thailand. I am a colorectal surgeon and my main work is colonoscopy. I take care of our surgical endoscopy in our hospital. They are different when we do selection for the procedure to remove colorectal cancer. In the colon, surgical resection have lower morbidity and shorter operative time compared to the rectum. So rectal surgery is more challenging. But for endoscopic resection, because of the thinner colonic wall and longer insertion part of the colonoscopy, cause more challenging for dissecting in the colon than in the rectum, which we are dissection outside peritoneum cavity and shorter insertion part of the colonoscopy, so it's easier to control the scope. For this lesion, invasive colorectal cancer, they need surgery for oncologic resection, and imagine that it is located deep down in the male pelvis who have big belly, it's not easy to do the TME. And these are the results after surgery, either laparoscopic approach or open surgery. We need surgical wound to enter abdominal cavity, and sometimes colostomy was created. Complications after the colectomy are roughly 20%, even with laparoscopic approach are the same. But these are just immediate complications after surgery. They have more complications later, such as cut-off suction from adhesion and complications related to the ostomy. As the same for rectal surgery, complications are roughly 22%, even with laparoscopic approach are the same. Compared to endoscopic resection, this patient is not easy to do the TME for him, but he underwent ESD for ascending colon lesion, and this is post-operative day 1. He can enjoy walking around the hospital and go back home in a few days. The data of ESD procedure from National Cancer Center Hospital in Japan, they found perforation is 3.5%, and almost all of them can manage by conservative treatment without surgery. As the same for multi-center data analysis for ESD procedure in Japan, show 5% perforation rate, which need emergency operation only 0.4%. From this data, it seems to be better for the patient if we can do endoscopic treatment for the colorectal lesion we found, but not all of them we can do endoscopic resection. We can do endoscopic resection for colorectal cancer if there are no risks for lymph node metastasis. But if they have a chance to have lymph node metastasis, surgical resection should be performed following oncologic resection principle. And we have to keep in mind that if there are carcinomatous area, it should never be cut into pieces. It needs en-bloc resection. From our own data, surgical endoscopy, Chulalongkorn Hospital, we found lymph node metastasis 10.4% in T1 colorectal cancer. From this data, 9 from 10 patients do not need surgery to remove lymph node. Only endoscopic treatment, as local treatment is adequate for oncologic resection. Thanks to our Japanese endoscopists, they found that malignant polyps are classified by depth of the cancer invasion as intramucosal cancer, superficial submucosal cancer, and deep submucosal cancer. The cutoff level of tumor invasion is 1,000 microns from muscular mucosa. If the cancer invades beyond this point, it has a chance to have lymph node metastasis. And with the superficial submucosal cancer without lymphovascular invasion or poorly differentiation, they have very low risk to metastasis to the lymph node. So in that JSCCR guideline in 2019, they recommend to do endoscopic resection for TIS and T1 colorectal cancer if the depth of submucosal invasion is less than 1,000 microns without lymphovascular invasion, no poorly differentiation component, and no budding. So it means that for invasive cancer, submucosal cancer, we have to do surgical resection to remove lymph node because they have a chance for lymph node metastasis. But for early colorectal cancer, which is intramucosal cancer, we can do endoscopic treatment as local excision, and it is adequate oncologic resection. So when we, as an endoscopist, when we found a lesion, we do in vivo characterized polyp by using magnified chromoendoscopy, either NBI or dye like in the cocamide, crystal violet. Then decide proper treatment for the patient, surgery for invasive remove lymph node, or endoscopic treatment, which have several techniques. Polypectomy, co-snare are very popular right now, and EMR or ESD. The technology which change wavelength of the light from white to blue and green, which hemoglobin can be absorbed, and with superficial vascular pattern and surface structure. We use classification to classify polyp and decide proper treatment. Nice classification, we look at the color, vascular pattern, and surface of polyps. In some cases, we need more details observation by magnified colonoscopy. Genetic classification are essential to differentiate malignant polyps. The most important is genetic 2B lesion, which consists of some invasive cancer. With the power of new endoscopy system like Olympus EVIS X1, We can detect more lesions and give accurate characterization by using better tech image technology like NBI. Then we can choose the proper treatment for the patient. You can see more detail in my YouTube channel, so please scan QR code to check it out. The principle of ESD is to dissect it into submucosal layer that we created by lifting solution, which I usually use the mixture of glycerol, adrenaline, and indicocamine. And so with this section, under the direct vision to remove polyps as on box resection in one piece. So the most important factor for the successful ESD procedure is the patient selection. JGES guideline for ESD EMI indicates selection criteria for ESD procedure is the lesion which endoscopic on-box resection is required. Basically, is the cancer. The lesion that contain the cancer, we need to do the on-box resection, so ESD should be performed. Or the lesion that have the submucosal fibrosis or the recurrence. Today, I will show you the 3 cases of the rectal lesion. Do you think all of these lesions need the surgery or just the endoscopic resection is adequate? Starting with the case number 1, located in the upper rectum. This is the NBI and indicocamine. Our endoscopic diagnosis is the 01SP, 3.5 centimeters in size. From the NBI diagnosis is the nice type 2, Genet 2B lesion. And my diagnosis is the non-invasive malignant polyps. You can see the detail of the depressed area in the center of the lesion is the Genet 2B. I decided to do the ESD for this lesion. Starting with the lifting solution, as I mentioned earlier, I usually use the dual knife to cut into the submucosal layer. The important is to get into the submucosal layer as soon as you can. And then for the ESD procedure, I use the taper cap to get the benefit to push into the dissected area. So the taper cap doing the open the space like here, you see, and then we keep dissecting into the submucosal layer, the brownish layer that we created. Using the dual knife, so we cutting into the blue line, and then the benefit from the taper cap, so is like open the space for us to doing the dissection. If the lifting is gone, or is because it's used glycerol is sometimes gone within the 20 minutes or something. So we do the keep injection. And if we found some of the vessel, as you've seen in this video, we use the coagulase. The dual knife can stop the bleeding. And we keep dissecting in the submucosal layer like this. And then the cap is doing like a one hand to open the space. And then when we can cut into the submucosal layer. In this lesion, they have the fibromuscular stalk. And so the muscular layer was tracted into the polyp. So we use the cap to open and then dissection layer by layer of the muscle away from the lesion. Like you see in this video, I'm dissecting into the core stalk that the fibromuscular layer is attached to the lesion, using the cap to open and dissection layer by layer of the muscle out from the lesion. So just keep the dissection line to the blue line, and sometimes the bleeding occur, but we can stop it by using the head of the dual knife and keep cutting until you see the blue line, see here, and then open it by using the cap like this, and then keep dissection. So yeah, this is the fibromuscular is also away from the lesion, and then we keep dissection to this is another part, and then keep cutting, and then to the backside of the polyps, like this. In this lesion, the previous hospital doing the tattooing before, you will see after the complete excision, like this. On the left side, that you see the back mark is this is after the ESD was done. So this is the ESG procedure for the upper rectum. The operation time is 2 hours. And the pathologic study come back as a well-differentiated adenocarcinoma, submucosal invasion 50 micron without lymphovascular invasion, no budding, and free margin. Additional CT chest and abdomen is no metastasis. So this lesion can safely and adequately removed by the ESD technique, and the patient is happy. And this is the follow-up 7 months after the ESD procedure. And then have the scarring in the center of the lesion is just the inflammation, and this will go soon. So the case number 2 is located in the mid-rectum. And this is the lateral spreading tumor, non-granular type, flat elevated. Size is the 3 centimeters. Our NBI diagnosis is the nice type 2 and Janet 2B lesion. The diagnosis is non-invasive malignant polyps. But in this lesion, you have to be careful because the lateral spreading tumor, especially the non-granular flat elevated type, have the chance to have the submucosal invasion like in this lesion. So I decided to do the ESD for this lesion. And this is the dissecting of using the ESD technique. And this is after the dissection at the same manner that I explained to you in the video before. And this is specimen. Operation time is 1 hour. And pathologics come back at moderate differentiation, adenocarcinoma, submucosal invasion that 1087 micron with lymphovascular invasion, but no budding and free margin. Additional CT chest and abdomen is no metastasis. In this patient, I recommend them to get the additional surgery later after the ESD. But the patient is almost 90 years old with a lot of the comorbidity. So after the discussion with the patient and the relative, they decided not to do the additional surgery. And then the patient is just want to do the follow-up, and then they still happy now. So the case number 3 is located in the lower rectum. As you can see in the middle picture, that the lesion is located close to the anal canal, and then more than half of the circumferential. So this is NBI. So my diagnosis is endoscopic diagnosis is lateral spreading tumor, granular type, nodular mixed type. The size is roughly 7 centimeters. From NBI diagnosis, it is nice type 2, the Janet 2A. So the diagnosis is tuberous adenoma without any part of the cancer. But in this lesion like this, it's very difficult to look at the detail because the size is too big. But after the observation, I thought that this is just the tuberous adenoma. So I decided to do the ESD for this lesion, start dissecting from the anal canal, as you see in the first picture. Keep dissection using the same manner of the ESD technique. And this is after the dissection, the more than half of the circumferential, and then deep down to the anal canal. And the procedure time is 4 hours. And pathologists come back as a tuberous adenoma with some part of the high-grade dysplasia. Lymphovascular invasion is not seen, and then it's a free margin. Additional CT chest and abdomen is no metastasis. And this is the follow-up in 8 months. All of the scar was healed and without any stricture. So this patient will get the benefit from the ESD procedure. But because of if we decided to go on for the surgery, maybe we end up with the APR or something. So this is another case, and then the ESD was done also, but this is maybe the biggest of my case. The whole circumferential ESD was done, and then this is after the healing. This is the other specimen and other cases that I do. That some of them is really long time procedure, like 8 hours or something. So yeah, this is the benefit from the ESD procedure. So if you found a lesion and you thought that the ESD or the endoscopic treatment might be get the benefit for the patient, but you cannot do it, just doing the photo, do not biopsy, do not do the tattooing, and send it to the endoscopic center that can do it. So for the conclusion, ladies and gentlemen, the power of nowadays technology of colonoscopy make we can get accurate characterization by details observation of colorectal polyps, then removed by proper and safer procedure, including oncologic resection for early colorectal cancer. Endoscopic submucosal dissection ESD is safe and can be one of the options for treatment of early rectal cancer. If there are any parts of the lesion was suspected cancer, it should be resected by en bloc resection. And thank you for your listening.
Thank you very much. Very excellent lecture, Professor Supakit, and fantastic video. Yes, thank you so much. So we will have the question in the last session again, and so we will move to the next topic. The next topic is TAMIS and TEM. Will present by Associate Professor Varamin Rensuvan. He is the Chief of the Colorectal Surgery Unit, Department of Surgery, Faculty of Medicine, Sriraj Hospital. So, Professor Varamin, please.
Thank you very much, Dr. Pawit. I would like to start and share my pre-recorded video because the time is limited. Can you see my video?
Yes, we see it.
Okay, let's start. Good afternoon. First of all, I would like to thank MESDA and the organizing committee, particularly Dr. Pawit Sutharat, for inviting me to join this online meeting. My name is Varamin Rensuvan from Colorectal Surgery Unit, Department of Surgery, Faculty of Medicine, Sriraj Hospital, Mahidol University, Bangkok, Thailand. My talk today is TAMIS and TEM. I have no disclosure. These are the topics I am going to present shortly, including local excision in rectal cancer. Next, we will talk about the conventional technique of local excision. Then we will move to TEM and TAMIS. And finally, I will mention about some technical problem in TAMIS and how to solve the problem. As we all know that the principle of rectal cancer surgery are both removal of usually, oncologic resection by TME should be implemented in clinically lymph node positive and also in a high risk T1 and T2 up to T4 rectal cancer, because the chance of positive lymph node are 10% in T1, 25% in T2, and even 50% in T3 tumor. Local excision is one of acceptable treatments for early lower rectal cancer. For curative intent, it is used in T1 tumor with low risk feature, including submucosal invasion less than 1 millimeter or SM1, no angiolymphatic invasion, no perineural invasion, no budding tumor, and the margin is free. There are three approaches of conventional local excision have been described, including transanal excision approach, transcecal or cascade approach, and transsphincteric or York Mason approach. The transanal excision is the most common local excision technique we use nowadays in early rectal cancer. The tumor size should less than 3 centimeter and located in the lower rectum within X centimeter from the anal verge. The limitation of this approach is the tumor located proximally in the middle or upper rectum. In the past, the limitation of transanal excision could be improved by either transcecal or transsphincteric approach. However, These two approaches have not been popularized because of their complications, such as wound dehiscence, rectal fistula, anal incontinence, and anal stenosis. I would like to mention a little bit about the technique of transanal excision. For the excision plane, we can perform in three planes. First is the full thickness excision that we can go beyond the ESD plane performed by the endoscopist. Second, excision in the submucosal plane, same as the endoscopist perform ESD. And finally, partial thickness excision between the inner circular and outer longitudinal muscle layer, which recently came by some experts that this partial thickness excision is better than ESD because of gaining more deep margin. And when compared to full thickness excision, partial thickness excision doesn't damage to the TME plane and possibly making salvage TME easier. Regarding the closure of the defect of rectal wall, if the excision is performed in the submucosal plane, we can leave the wound open for secondary healing. In full thickness excision, it is recommended to close the defect with suturing either by interrupted or continuous stitch. Because if you leave the wound open, it takes quite a long time for secondary wound healing, and most patients have to suffer from anal pain and passing mucus body discharge for a few months. If the defect is small, you can coat it vertically to avoid luminal narrowing in the large defect. It is better to close it in transverse or a horizontal fashion. As I mentioned before, the only limitation of transanal excision is the lesion located in the middle or upper rectum. This limitation of transanal excision was solved by the advent of transanal endoscopic microsurgery, or TEM, which was introduced by Gerhard Busch, a German surgeon in 1982. TEM can be used for performing either submucosal or full thickness excision in the lesion located at the middle or the posterior aspect of the upper rectum. This procedure was commonly used in Europe and UK, but slowly be adopted in US. The equipment is expensive and the procedure is difficult to perform and technically demanding because you have to do single port surgery in the limited space. At present, there are two platforms of TEM from two companies, one from Stott company called TEO and the other from Richard Wood company. Both platforms comprise of a 4 cm in diameter rigid rectal scope. The working space in the rectal lumen is created by insufflation of carbon dioxide as in laparoscopic surgery. During performing excision, the lesion by TEM, we have to look at the lesion in the face down manner. Therefore, we have to position the patient depend on the location of the lesion. If the lesion is at the posterior wall, we have to put the patient in a lithotomy position. If the lesion is at the anterior wall, we have to position the patient in a prone position, while we position the patient in a lateral decubitus if the lesion is at the lateral wall. What is the difference between TEM and conventional transanal excision? There has been a study from Minnesota group many years ago comparing between TEM and conventional transanal excision in early rectal cancer. This study demonstrated that the tumor excised by TEM was larger and located farther from the anal arch when compared to the tumor excised by transanal excision. When looking at the resection margin, there was less positive margin in TEM group when compared to the conventional transanal excision group. Let me show you a TEM case that we were consulted from the gastroenterologist many years ago. This patient has a 2 centimeter polyp at the middle rectum, 10 centimeter from the anus. The gastroenterologist removed it by polypectomy, and pathology report was tubular adenoma with locate dysplasia. As you can see in this slide, I think there was some residual adenoma was left. 1 year later, this residual or recurrent adenoma was removed again with polypectomy by the gastroenterologist, and the pathology report was tubulovillus adenoma with locate dysplasia. 6 months after that, a recurrent fat polyp with centrally displaced was detected. Biopsy was performed by the gastroenterologist and reported villus adenoma with high-grade dysplasia. At that time, they consult us for surgery. We performed endorectal ultrasonography and found that the lesion was T0N0, located at the posterior wall of the middle rectum. As you can see, that is what at the seminal vesicle level, which was quite difficult to remove by conventional tunnel excision. We decided to perform full thickness local excision by TEM. Before placing the rectoscope, we usually dilate the anal canal with 4 fingers. The rectoscope was placed, then the cap with working and camera pod was attached to the scope. Then CO2 was insufflated. The resection margin was marked with cautery. Then full thickness excision was performed with cautery. Sometimes you might face with a large feeding vessel which could be cauterized. Then you can close the defect with 2O or TO absorbable suture. I think this is the most tedious part of the operation. Nowadays, using a barred suture can facilitate you to close the defect easily. This was the specimen that we excised, and the pathology reported tubular adenoma with focal high-grade dysplasia. No dysplasia at the lateral and deep margin. These were the findings of flexible sigmoidoscopy during 1 and 3 months after surgery. And this was the finding during flexible sigmoidoscopy at 6 months after surgery. You can see the nice healing scar. As I mentioned before, the limitation of using TEM in local excision for the rectal tumor is the expensive cost of the equipment. Until the last decade, in the era of single port surgery, the replacement of TEM by anal minimally invasive surgery or TAMIS, what happened? This technique was first introduced by a group from minimally invasive surgery center in Florida in 2010. They used the seal port, which is a single port platform, to place in the anal canal, and using standard laparoscopic surgery equipment to perform excision of the rectal lesion instead of TEM. Recently published report by their group show a promising result in 200 patients with benign or malignant rectal tumor operated by TAMIS. In this study, the average positive margin rate was 7%, and average 5% of fragmentation rate of the specimen was reported. At present, there are many single port surgery platforms available in the market that we can use in TAMIS surgery. But the most popular platform actually designed for TAMIS is gel point pad. As we all know that the TAMIS platform is now also using for TAN-anal TME. The TA-TME was first proposed by Dr. Lacy in 2011, and this topic will be presented by Professor Ito and Dr. David in this meeting. This is a study comparing the outcome of TEM versus TAMIS in local excision for the rectal tumor. The tumor characteristic and tumor height from the anal verge were not different between two groups. The TAMIS group could have a small lymph node and the excised specimen volume was bigger than the TEM group. However, the estimated blood loss was higher in the TAMIS group. The complications and the recurrence rate were not different between two groups. Nowadays, you can also use the TAMIS platform and standard laparoscopic surgery equipment to perform local excision. If you don't have the TEM equipment, I think the TAMIS is more cost effectiveness. Regarding the technical problem during perform TAMIS, two obstacles that you have to deal with are smoke from rectal cautery and flapping of the rectal wall from CO2 insufflation. These two problems can cause the inadequate exposure of the lesion and finally making difficulty in dissection and suturing. Nowadays, you can overcome these two problems by using air seal system insufflator to maintain a stable pneumorectum and facilitating smoke evacuation. But of course, the cost have to be increased. To correct the problem of flapping rectal wall, the company launched the new generation of gel point pad, which include an insufflation stabilization bag to maintain a stable pneumorectum. You can try to use a cost-effective technique to facilitate stable pneumorectum by using an inline groove at a reservoir, as in this report. If you don't have an air seal system or insufflation stabilization bag, either active or passive smoke evacuator, as well as the cautery probe with suction, can also be used to get rid of the problem of smoke during dissection with electrocautery. If your budget is limited, you can also use a homemade gold port with small size wound protector instead of a commercial TAMIS platform. In conclusion, ladies and gentlemen, local excision is acceptable for curative treatment in early rectal cancer with low risk histologic feature T1 N0M0 lesion. Preoperative clinical imaging, for example, rectal ultrasonography or MRI, is very important in the decision for whether local excision or oncologic resection will be performed. Conventional TAN-anal excision is an appropriate in lower rectal lesion, particularly the lesion that's close to the anal verge and easily hooked by your finger during digital rectal examination. And finally, TEM and TAMIS are suitable techniques for the lesion in the middle rectum and posterior aspect of the upper rectum. I hope that we can meet in person face-to-face during our next MESDA meeting. Thank you for your attention and stay safe from COVID-19.
Okay, thank you very much, Professor Warren. Your very nice lections.
The next topic will be laparoscopic TME by Dr. Weerapat. Dr. Weerapat is very talented in the field of colorectal surgery, especially for laparoscopic approach. Dr. Weerapat is currently the attending surgeon of colorectal Department of Surgery, Faculty of Medicine, SISX Hospital. Please welcome Dr. Weerapat.
Hello, everybody. Do you hear me?
Yes, we hear you.
I would like to share my slide first. Do you see my slide?
Yes.
Okay. Good afternoon, everyone. I am Dr. Weerapat Chatpanchachai from SISX Hospital, Khon Kaen University, Thailand. Today is my honor that MESDA have invited me to present in this valuable conference. And my topic today will be about laparoscopic TME. We begin with the background and history. In 1908, William Ernest Mouse proposed the abdominal perineal excision, or APE. In that time, most of the surgeons usually perform blunt dissection, which results in 25% positive resection margin. But in 1982, everyone knows about this doctor. His name is R.J. Bill Hill. He proposed the word TME, or total mesorectal excision. And his invention have changed the paradigm and principle of rectal surgery. He said we should use sharp mesorectal excision along direct vision, and we have to remove the rectum as the entire envelope. And here is the mesorectal fascia. It is the fascia that envelop around the rectum and the structure with lie inside, which include the mesorectal fat, the lymph node, and the lymphovascular structure. And how to understand the principle of the TME? First, you have to understand the anatomy of the mesorectum. And here is the anatomy of the sagittal view of both female and male pelvis. And the mesorectal fascia is like in anterior, in female is like between the rectum and vagina in rectovaginal septum. And in male pelvis is lie between the seminal vesicle and prostate gland and anterior to rectum. And in posterior mesorectal fascia, both gender is lie just anterior to the presacral fascia. The mesorectal fascia is run caudally and end in the level of the pelvic floor, which I label in the purple line. In the coronal view, the mesorectal fascia is run medially to the pelvic side wall and also run caudally to the level of the pelvic floor. And here I will talk about the level of the rectal transection. It's depending on the location of the tumors. Means if the tumor is located in the middle or lower rectum, we should perform the complete total mesorectal excision. Means we have to move the entire mesorectal fascia down to the pelvic floor. And if the tumor is located higher, like in the rectal sigmoid junction or in the upper rectum, we don't have to do the complete TME. We just have to transect and remove the specimen distal to the rectum for about 4 to 5 centimeters. That's called the AME, or adequate mesorectal excision. And that is the tumor-specific mesorectal excision. And this is the definition. And in the past, when we developed and initiate the laparoscopic colorectal surgery, most of the doctor and surgeon have concern about its efficacy, whether it will be inadequate resection that can lead to poorer long-term oncologic outcomes, or maybe it will cause the post-site recurrence, and some have concern about the new techniques mean longer operative time and may lead to poorer operative outcomes. And in the past, there is several landmark trials that try to prove the benefit and efficacy of laparoscopic versus open approach in the colorectal surgery. Begin with the COLOR trial in 2000, conducted in Netherlands, and is the study about feasibility of laparoscopic versus open in colon cancer. Then in 2007, we have COST trial. And this study also tried to prove the efficacy of laparoscopic versus open approach in colon cancer. Then we have CLASSIC trial in 2007 in United Kingdom. Then we have the COLOR 2 trial in 2013. And this is the multi-center RCT about the efficacy of laparoscopic versus open approach in rectal cancer. Then in 2014, we have Korean trial. And this study is about the study of efficacy of laparoscopic versus open approach in locally advanced rectal cancer that underwent concurrent chemoradiotherapy. And all 5 landmark trial, some study is about colon, some study is about rectum, and some is both colon and rectal surgery, but all study try to prove the efficacy and feasibility of laparoscopic versus open approach. And all of the study have shown that laparoscopic is comparable and non-inferior to open approach in the term of oncologic outcomes. In 2015, we have one study that seems to be the problems. It's called ACOSOC Z6051 trial. In Canada, is the multi-center RCT. In the patient is locally advanced rectal cancer that underwent CCRT. And this study tried to prove that laparoscopic is not inferior to open approach in the term of distal resection margin, circumferential resection margin, and quality of the TME specimen. And the result of this study showed that the laparoscopic approach have more positive circumferential resection margin compared to open approach. When the result of this study come out, all the laparoscopic surgeons have paused and doubt about the efficacy and feasibility and the dangerous about the laparoscopic rectal surgery. But if you look closely, the oncologic outcome in this study is just the pathological oncologic outcome in 3 parameters. When we follow up the patient in the ACOSOC Z6051 for 3 years, and the long-term oncologic outcome come out, it shows that laparoscopic have equivalent local recurrence and disease-free survival to open approach. So the laparoscopic surgery in locally advanced rectal cancer remain feasible and safe. Nowadays, there are several meta-analyses and systematic review about the efficacy of laparoscopic and open rectal surgery. And all of it have concluded that laparoscopic is safe and efficacy and effective. And some parameters may be better than open approach, like the length of hospital stay and post-operative pain. And now I will show you the surgical step in laparoscopic TME from my, I will show you the video from my real patient. First, begin with the port site incision. I usually do the 12 millimeters camera port infra-umbilically, and the surgeon port is located in the right lower quadrant area. The right hand is usually be 12 millimeters port because we can insert the endostapler, and sometimes we can insert the intracorporeal suturing device through this port. And the assistant port is located in the left lower quadrant side. And the lower one around here will be the specimen removal port. We can extend this port to the incision for about 4 centimeters to remove the specimen. And here I will divide the video into about 5 steps. We begin with the medial to lateral approach and how to access to the TME plane. Okay, the assistant must be track the pedicle like this. And the incision, we begin by incise the peritoneum around the promontory of sacrum. And if we do the correct plane, the carbon dioxide will inflate into the plane. We dissect separately and caudally. We dissect the peritoneum covering the IMA pedicle. And we encircle it, and I usually secure it with the plastic hemlock clip. And this clip is a little bit too big clip. And we divide it between the hemlock. And then we dissect the IMV. We usually can transect it at the same level of the IMA. Then we transect it, and we continue the medial dissection through the embryonic plane. We know that we have adequate medial dissection when we see the psoas muscle like this, and anatomy will be like this. I usually pack the gauze in the medial dissection that we have been performed to do the easier lateral approach by see the gauze. The lateral approach, we do separately as much as possible. And we do to the pelvis, lateral approach in the left side to the pelvis. This is lateral dissection in the left side. And then we do the lateral dissection on the right side. The TME plane or the holy plane is the avascular plane that I dissect in this video. We can follow it to the level of the pelvic floor. I usually do it in the posterior side first. Okay, and then the next step is the anterior dissection. I divide it into two parts, in male and in female. We begin with the male anterior dissection in male, dissecting the anterior peritoneal resection. In male, we have a seminal vesicle anteriorly. We dissect the peritoneal reflection anterior. In this case, I accidentally injury to the surface of the seminal vesicle, which is will be okay. And here is the seminal vesicle. We can follow the plane anterior to rectum and posterior to seminal vesicle down to the level of the pelvic floor. And the assistant is very important. In this case, the assistant must track seminal vesicle, and I follow to the plane that I have shown you. Okay, now the anterior dissection in female is quite different. Let me stop here first. The uterine can be tracked anteriorly, either by using the suturing device, or the assistant can be tracked anteriorly. But in this case, I used a special device, is the uterine elevator insert in vagina. And the anterior peritoneal reflection is dissect just like in male patient. But the difference is anterior, there is the vagina, which is quite close to the rectum. It's slightly tight. Sometimes you have to use sharp, and sometimes you have to use blunt dissection to identify the correct plane. And here is the boundary of the vagina and the rectum. In my opinion, the anterior dissection, the tissue plane in male anterior dissection is looser or more loose than the female. But the overall dissection in rectal surgery in female is much easier than male because the female pelvis is wider and bigger. Now it's about the rectal transection. We divide into TME and AME. First, the TME, we transect the rectum to the level of the pelvic floor. Here you will see the pelvic floor. You have to transect circumferentially before you divide the rectum. This now you apply the stapler as close to pelvic floor as possible. Usually at this level, we have to use more than one staple cartridges. And this I use 60 millimeters and another 25. And here is the pelvic floor and the rectal stump. Then we perform the anastomosis. We have to ensure that the staple line between first and second and maybe third staple line is in the good alignment in the same line. Now the rectal transection in AME, as I mentioned before, if the tumor is slightly high, like this case, is the tumor is located in the level of peritoneal reflection, we can transect the rectum for about 4 to 5 centimeters distal to the level of the tumor. We don't have to do the complete TME. Now this video shows the transect of the mesorectum. And then in this level, is always use less number of staple cartridge because the rectum in this side is not wide. Okay. And this is another important topic. Is a lot of study have shown that number of staple cartridge have related to anastomosis leakage. Like in the first study, they show that the staple cartridges more than 3 have caused the anastomosis leakage for about 20%. And in the second study that I have bring to show you, they show that number of staple cartridges more than 3 have led to leakage for about 26%. And this is the study of Dr. Masaki Ito. It's a very good study. He said that we usually insert the endostapler through the right lower quadrant port, and through this alignment, we have to transect the rectum in the transverse fashion, and it will cause more stable cartridge. But if we use the vertical rectal division by insert the staple cartridge through the suprapubic port, we can decrease the number of staple cartridges, and it leads to lower rates of anastomosis leakage. Actually, there is several topics about the laparoscopic TME, but I have only 20 minutes, so that's all I want to say. And my conclusion is TME is the standard surgery in rectal cancer that unable to remove by local excision, as the technique that Dr. Supakit and Dr. Vromin has mentioned before. And the second conclusion that nowadays laparoscopic TME is safe and feasible. Thank you for your attention.
Okay. Thank you very much, Dr. Viraphat, for your very nice lecture. So we will move to the next topics. The next topic is about robotic TME. They will be presented by Professor Vitun Chinsawang Mathanakul. Professor Vitun is the chief of the Division of Minimal Invasive Surgery at Sirat Hospital, and he also the pioneer of robotic colorectal surgery of Thailand. Today, he will give us about the topics of the robotic TME. Please, Professor Vitun.
Thank you, Professor Bovit. Let me share my slide first. Could you see my slide yet?
Yes.
Okay. I'd like to declare I have no conflict of interest. When we look at the robotic surgery, someone may say it's just a dream, but believe it or not, during this COVID situation in Thailand, we still have at least 2 institutes that already install a new robotic machine during the COVID pandemics. And I heard from the company that perhaps next year, another 2 or 3 institutes may get the new robotic machine as well. So why we have such a lot of famous technology like that? When we look at the robotic surgery platform, someone may call it like a robot-assisted laparoscopic surgery or else. It is one of the new challenging surgical technologies actually for a few decades. The most famous, probably the Da Vinci surgical platform, was among the first few technology approved by the US FDA since 2000. And to date, the popularity of robotic assist surgery seems to be increasing. If you look at the operation that FDA approved since 2000, especially for the field of general surgery, it covers a wide variety from cholecystectomy, anti-reflux procedure, gastrectomy, esophagectomy, actually colectomy, and other. Nearly all organs inside the abdomen could be done in whatever done by laparoscopic surgery. It could be done by robot as well. So when we look at the component of Da Vinci surgical platform, it consists of 5 key elements. One is the economical design surgical console. You can select between 1 or 2 console. If you have to teach someone, you want to do as a dual console. And the next one is a patient side card that gonna stick to the patients on the table. The third one is an interactive robot arms that could be moved very extensively with a wide range of motion. The fourth one is a 3-dimensional high-definition stereoscopic vision system that can see the operation with a very stable platform camera. And the last one, and especially probably the most important, is an EndoWrist exclusive instruments. The EndoWrist can support the surgeon by giving the 6 degrees of freedom. You can move, as you can see on your own wrist. You can probably turn around 2/3 or 270 degrees around. But for the robotic system, you can turn around 1.5 turn or 520 degrees, and in different direction as a 6 degree of freedom. So the Da Vinci platform could provide surgeons with a superior visualization, enhanced dexterity, a greater precision, and ergonomic comfort when compared to the other surgical approach, either open or laparoscopic surgery. So it makes a possibility for a well-trained surgeon to perform MIS procedure involving the complex dissection and reconstruction. So far, nearly 20 years, I think the Da Vinci platform has up to the 4th generation that called Da Vinci Xi. That could say that it's probably suitable for general surgeon. When you see the stable camera on the left-hand side of the robot, it's very stable compared to the right-hand side. Even though you got the best assistant, camera holder, there's still got some shaking, a bit of shaking that may cause you a fatigue when you do the operation for quite a long time. Right? And the most important secret of the EndoWrist, you can gently manipulate the tissue precisely, because the tip of the instrument you will see there is about 1 or 2 millimeters wide. So you can deep down and do very fine dissection. Right? So these all characteristics are considered to facilitate the significant steps of intra-abdominal operation, such as dissection, control of blood vessels, mobilization of the bowel, and dissection into the deep pelvic cavity. that I would like to show the example of the robot-assisted TME. Basically, when I do laparoscopic surgery, I prefer to use the harmonic scalpel rather than the hook like this one. But the harmonic scalpel in robotic platform is not flexible. It's not you cannot flex like the 6 degree of freedom like the hook like this one. So I decided to use this kind of simple dissection by cautery, right, as you can see. And I do not actually stick with either anterior, lateral to medial or medial to lateral approach. It depends on which way is easier than another way. So you can see that this, when I can identify the IMA, I try to dissect around, get the lymph node out as much as possible, and I resect the IMA with the staple, vascular staple, to make sure for hemostasis. And I prefer to use the torch tape to assist for the tension and traction, especially when we have to do surgery deep down into the pelvic cavity like this one. And I just try to move around, the mesocolon from the both sides, and then as you can see, as the previous laparoscopic TME mentioned, that the most difficult part probably at the anterior side of the rectum, because sometimes the structure, especially for female, like a vagina, is going to be very close and very thin, and this area you may get injury to vagina very easily. And you look at the robot visualization, it's very clear that you can see the plane sharply, and you can dissect deep down, see, toward the pelvic cavity, this one, right? And this is a seminal vesicle that you can avoid the injury to the seminal vesicle easily if you can see the three-dimensional crispy clear visualization like this. This tumor is very, very low, so I need to let someone help us from the below to make sure where is the edge of the tumor. And sometimes I use the hand assist to do the anastomosis like this one, because I have to open up to remove the specimen anyway. Oh, sorry. Right. So when we look at the concerning issue of robot or laparoscopic rectal resection, especially for TME, we have to make sure that we get a good quality of TME excision sample. We have to guarantee the oncological outcomes. If we can, we would like to preserve the nerve and urogenital function after surgery. The operative time is one of the big issues that the beginners of robot may take more time when compared to laparoscopic TME. And postoperative short and long-term outcome have to be compared between laparoscopic and robotic surgery. And finally, the cost. At the moment, it's for sure that the cost of the robot is about 2 or 3 times over laparoscopic and open surgery. When we look at the evidence-based study in the literature, when compared to conventional laparoscopy, the robot TME associated with a significant fewer conversion rate, that you have to take more time to get that benefit as well. The robot TME is useful for sphincter saving operation achievement. It has been clear in many literature. And the robot TME for rectal cancer seem to be associated with the early recovery of normal voiding and sexual function compared to patients who underwent conventional laparoscopic TME. This has been demonstrated in many papers. similar to the successful of robot prostatectomy in urology. And robotic surgery for rectal cancer also satisfy all measures of pathological adequacy of TME or AME in some cases, and also offer the acceptable oncological outcomes. The robot resection provide a better post-operative short-term outcome. For example, they provide a less blood loss, shorter post-operative hospital stay, lower rate of urinary retention, a lower rate of post-operative complications such as sickle cell infection, or less anastomotic leakage as well. The robot TME provide a similar post-operative long-term outcome, either the lap or open surgery. When we look at the 3 to 5 year survival outcome and local recurrence among open laparoscopic and robot assist TME in recent literatures. This is one of the most expected randomized control for robotic compared to the conventional and open surgery. It's called the RORA trial. Unfortunately, the result that have been published in 2017 in JAMA seem not to be happy as we expected. This trial actually spent over 6-7 years, and it started at the beginning of the robot rectal resection. This is also the international multi-center prospective trial in about 470 cases from 29 centers in 10 countries. That too many places that may cause the result might not be satisfied. For example, they do not demonstrate any significant difference between lab and robot in terms of conventional conversion rate, CRM positivity, TME completion, the rate of intraoperative complication, the mortality, and other post-operative complications. Anyhow, in some subgroup analysis, they found that robotic surgery in TME may decrease the conversion rate when compared to the lab in men, especially for the fatty male with a narrow male pelvis. So I think the limitation of the RORA trial probably comes from too many surgeons with different robotic experience, because the median experience is about only 50 robotic cases, vary from 30 to 100 in interquartile range. So that may cause no significant benefit when we analyze the whole data. I think in the future study of similar design might be get involved more experienced surgeon, so we may get good news in the future. When we look at the how famous that the robots have been done globally, you can see in this slide that since the launching of Da Vinci Xi or the 4th generation, they could make the operation easier because it's a 4-quadrant approach. You can swap between camera and the arms, any arms, because they use the same size of the port, of the 8mm port, rather than 12 plus the other 3 8mm port in the previous generation. And you can see since 2017, it seems that the general surgery operation seems to be overcome the total case of the robotic surgery have been done by gynecology and urology. In United States, they install, I think, over 2,000 robot machines that may benefit to general surgeon to get wide range of operations, such as corectomy like this, as I showed you before, and also even the simple cholecystectomy or hernia operation. And you can see here, since 2014, with the Da Vinci Xi, it seems that the colorectal operation is going to be famous more and more. And this is the evidence that shows that 1 in 2 colorectal surgeons, that means 50%, are using Da Vinci system in the US. And about 83% of 2017-2018 colorectal fellows were trained on Da Vinci system. That's going to be the future surgeons for the robot army. And average colorectal fellows complete up to 75 Da Vinci cases during their training. It seems to be that in the future, the robot surgery may occupy instead of the conventional laparoscopic surgery. So let me show our experience of Da Vinci platform in Sirat Hospital. We start since 2007. It's over 13, 14 years. For the first 5 years, it's very slow, increasing in number. In 2017, you can see that we got more and more surgeons interested to do robotic surgery. So in general surgery, they like climbing up a trend. So far, we have done nearly approaching 500 cases in the over 20 procedures from top to toe. I can say that from esophagectomy, nascent fundoplication, gastrectomy, hepatobiliary surgery, even a Whipple operation, and also for colorectal surgery, varying from the sigmoidectomy to low anterior section, TME, or even APR. And at the moment, we got a new champion, Dr. Warabut. He's going to be done on a lot more bariatric surgery. For the last few years, he performed over 70 cases. I think it's going to approach 100 cases pretty soon. And also the lap hernia, using the TAP technique to do robotic surgery as well. So in conclusion, Mr. Chairman, ladies and gentlemen, the robotic surgery, especially for colorectal surgery, is still at the early stage and may need more evidence-based support. The current studies regarding the use of robotic assist laparoscopic surgery in GI cancer reported unsettled consensus yet. The development of surgical techniques with the latest model of Da Vinci Xi, as well as other future platforms, may encourage the robot surgery more applicable for colorectal surgeons in the near future. So many studies demonstrated the feasibility and benefits tendency anyway, and the cost benefit need to be carefully judged. In conclusion, I do believe that the robotic TME is future for colorectal surgeons. Thank you for your attention.
Thank you very much, Professor Vitun, for your excellent lecture. So we will move to the next topic.
Yeah, the next topic will be laparoscopic ISR by Professor Bunchai. Professor Bunchai is one of our famous colorectal surgeon in Thailand. Now he is currently a lecturer and colorectal surgeon from Departments of Surgery, Faculty of Medicine, Washira Hospital. Please welcome Professor Bunchai.
Dr. Joe, thank you, Dr. Joe, for your introduction. You can see my slide?
Yes, we see it.
Okay. Okay, I will to start off my slide. Dr. Joe, can you see off my slide again?
Yes, but can you show in presentation view? This is not presenting. Okay.
I will.
อาจารย์น่าจะกดตรงการนำเสนอภาพนิ่งนะครับ แล้วก็กดนำเสนอครับ ตั้งแต่ต้นนะครับอาจารย์ตรงตั้งแต่ต้นตรงนั้นนะฮะน่าจะอย่างนี้ครับอาจารย์คลิกตรงคำว่าตั้งแต่ต้นตรงบาร์ข้างบนเลยก็ได้ครับตรงนั้นเดี๋ยวมันจะโชว์ตั้งแต่ภาพแรกเลยครับตรงนั้นนะตรงล่างลงมานิดนึงครับอาจารย์ครับไม่ครับ
Okay. Okay, thank you for Dr. Joe to your assignment and introduction. Okay, I will to start off my slide, the laparoscopic ISR interspeculate resection. Okay, at first I will to thank Dr. Pawit and the MESDA committee to admitted me to share the experience about the laparoscopic ISR. I am Dr. Bunchai Ngamsrimat from the Wachira Hospital. This is my hospital. It's located near the Chao Phraya River, the main river in the center of the Bangkok. I'm the discussion for this topic. This is my outline today. It is the web definition of the background of ISR, the conflict issue, the result and quality of life of the ISR, and my step of the laparoscopy ISR with my practice. Before I go to the next slide, I will to talk about the surgical decision making. I think that when we face of the low-lying of the rectal cancer, the decision is depend on the four topics about the oncologic outcome, quality of life, surgeon experience, and the patient prefer. That I think that we will to balance of the four topics to give the patient to the good option. For the definition and the background, ISR is the procedure designed to the preserve of the anal function for the very low rectum cancer. I mean that the 5 cm from the anal verge and 3 cm from the dentate line. The ISR has the first pronounced report by the Professor Giselle in the 1994 in the open technique. After that, for the 5 years ago, the Professor Watanabe and his colleague has the report of the laparoscopic ISR in the 2000. This is the original paper of the intersphincteric resection for the low rectum tumor, and laparoscopic ISR is a report by the Professor Watanabe. For the definition, we will do classification of the ISR into the 3 groups to the level of the incision. At the dentate line is so the partial ISR, and in the anal verge is the total ISR, and between it is the subtotal. On the picture on the left side, you will see of the picture of the tumor location. I think that the type 2, the tumor location is suitable for the ISR, and you be careful for the type 4 that have the invade of the sphincter, that some surgeon do the partial external sphincter resection. I think that is not harmful. For the indication for the lower lying jugular anal rectum cancer, 5 cm from the anal verge and 3 cm from the dentate line. The depth of the tumor is the T1 or T2 and the select T3. I think that the T4 is not suitable for the ISR, and you will to have the evaluate of the anal function. For the overall general for the ISR is the morbid mortality. The mortality is less than 5 cm and the morbidity is less than 30%. And anastomosis leakage is less than 10%. And the most post-operative complication is the anal stricture, less than 16%. And the most is the pelvic infection is 11%. From the meta-analysis of the part that he collects, meta-analysis from the more than 10 series of the ISR, he have the collection of the data. Overall surgical morbidity is less than 30%, and the small of the mortality. Most complication is the pelvic abscess and the anal stricture. But except you will see the except of the early period of the ISR from the coral paper, it have anastomosis leakage so high. For the issue of the laparoscopic or the open technique, we have the meta-analysis from the Professor Chen and his colleague to compare about the laparo and the open technique by 5 studies. He found that the morbid mortality is the found of to less in the laparoscopic. Anastomosis leakage is similar to the both sides. Hospital time, it is laparoscopic is better. For the operative time, it less in the open technique. For the blood loss, it favor to the laparoscopic technique. For the circumferential rectal margin and the distal rectal margin, is the similar for the both sides. And the number of the lymph node harvest is the better in the laparoscopic. For the oncologic outcome about the disease-free survival and the overall survival until the local recurrence rate, it is seem to similar in the both sides. Professor Chen and his colleague had the conclusion the laparoscopic is compared to the open technique. In general, for the oncologic outcome of the ISR, it is the local recurrence less than the 30% and no differ from the APR. From the series of the cyto and the cori, the local recurrence only the 5% for the ISR, and 5-year disease survival is the 69% for the ISR, and 73% for the APR is not different. For the issue of the distal rectal margin, in general, we know that the local recurrence was the impact by the circumferential rectal margin than the distal rectal margin. We have many papers to support it, and one of the series is from the Professor Jim Lam. He said that intramural extension beyond the gross tumor age generalized less than 1 centimeter. For the retrospective analysis of the Professor Philip Menko from the German, he has to find the minimal distal rectal resection margin in the low rectal cancer. He collect the data about the 88 person who have rectal cancer and divide to the two groups. In the one group, if the distal rectal margin is less than 1 centimeter and the other is more than 1 centimeter. He collect the data about the 5-year overall survival. It is the same. That's 93 and 95%. It's same as the local recurrent free survival. That is the 92 or 93%. It is similar from the margin 1 centimeter. That's the main goal. His conclusion, the 1 centimeter of the distal rectal margin is enough. We have many papers about the distal rectal margin for over more than 10 years, but we have some the conflict of the distal rectal margin. I have to show you about the paper of the Professor Hayden, that he said that about the tumor scattering after the neoadjuvant therapy for rectal cancer. He said that after the radiation, the cause also cannot be used to determine residual tumor. He find that the residual tumor will be found up to the 3 centimeter from the distal cross ulcer. He said that the standard 2 centimeter margin is not enough. But in the finally, we found that this parameter was not associated with the poor prognosis factor and the oncologic outcome. For the issue of the quality of life, functional outcome for the ISR is the main problem, and in the other of the low-lying anastomosis. The patient will come to visit us with the urgent defecation, incontinence, evacuation disorder, and increased stool frequentation. Because of multifactorial factor, the direct trauma of internal sphincter is one, and interruption of the reflex compliance and the physiologic property of the neorectum differ than normal. For the some case of the part of the radiation therapy before, it will be impact of the anal function and anal sphincter. This is a meta-analysis from the past. He will see to the quality of life from the many paper. You will see that after the ISR, for many paper, the bowel motion per day is the 2 or 3 times per day, and the good continence is more than 60%, and the major incontinence is less than 10%. For the type of anastomosis, in the POW or non-POW, we learn that the POW and non-POW is similar quality of life. Nowadays, we know that the colony pulse has a short-term advantage that are by exception, but in the long-term benefit, had a little bit benefit. This is my step and my technique. I have in my practice, I have to the part for the do ISR, intra-abdominal part and the perineum part. I think that intra-abdominal part same like the Dr. Vitun and Dr. Vilavat in the Lapalo TME. My step is the ligation of IMA median to the lateral and the mobilize the rectum to the floor of pelvis. That's when you do ISR, you will clearly to identify of the pelvic floor. In the picture, you will see in the picture on the right side, you will see the hiatal ligament that the insert of the coccyx and the anal canal. You will cut it to mobilize freely of the rectum, and you will see the lining muscle of the pubococcygeal and puborectalis. And you will turn to the perineum part. I'm almost always to use the Lone to expose of my anal canal. And I will use the marking of the circumferential incision at the dentate line from the partial ISR. Before I dissect along the intersphincteric plane, I will to close of the distal rectal stump to prevent of the tumor seating. And I will to free up the draw direction. After I free up the rectum, I will to retrieve the specimen trans anal root and anastomosis with my manual anastomosis by the YQ3O. You will see have the anterior dissection. You will to be careful about meticulous to do it. Because of if you do the long pain, you will see in the picture on the prostate and neurovascular button that locate on the 11 o'clock and the 2 o'clock that you have a dissection in the long pain, you will have some bleeding. This is of the short video that I will do ISR in the last month. I will show you. Okay, detail of my the last slide. I conclusion the ISR is the safe procedure for the sphincter preserved wing surgery compared to abdominal perineum resection. However, the select case should be to consider the adverse function effect should be operative evaluate. And I think that the laparoscopic ISR have the safety and insufficiency for the select case in the post-operative pain and hospital time. Okay, thank you for your attention.
Thank you very much, Professor Bunchai. We will keep the question for the last topic. The next topic will be what should we know about TATME by Associate Professor Pawit Sutharat. Professor Pawit is top rank of the TATME in Thailand, and he is very well known of colorectal surgery, especially for minimally invasive approach. Now he currently is a chief of division of colorectal Department of Surgery, Faculty of Medicine, Chiang Mai University. Please welcome Professor Pawit.
Thank you very much, Professor Tapon, for your introductions. So, did you see my slides now?
Yes. Yes.
Yes. Okay. Okay. We start. Today my topic is about what should we know about TATMEs. So the first slide shows about the timings of the rectal cancer surgeries. See first from the mice and Professor Hill in the 1979, such as the laparoscopic surgery in 1990, then 2095 anesthetic surgeries and also robotic surgery. And the TATME was performed the first case in the year 2009 by Professor Andrea Lacy and Professor Patricia Silla together, and then the robotic airlines. And from the year 2019 is a 10-year anniversary of TATMEs. This is all key persons for TATME: Professor Hill, Professor Silla, and Professor Lacy, and Cecil Lacy used the name of Cecil to give his approach, the Cecil approach. First, we need to know about the TME's indications from the St. Gallen consensus. They show that indication for patients who perform TMEs for narrow pelvis, obesity, bulgy mid and distal rectal tumors, AP resections. You can use an AP resection or ISR or another benign procedure. But now, after we listen Professor Ito speak about today, I think this is the indication we share in the future. That's to advance case, for the example of lateral pelvic node dissection for prostatectomy, cystectomy, and recurrent tumor, and also GIST. So this one of my teacher, Professor Ito. We visited his hospital about 2 years ago to learn about TATME with him. So I think now we know that he changed the indication for TATME to use in our case with the middle and rectal cancer, and also the indication will develop now. The TATME has two types. The first type is used for a tumor that location about 5 to 6 centimeters from the anal verge. You need to why 6 centimeters because the length of the prosthesis that we use, the transanal platform is length is about 5.5 centimeters. First, we insert the prosthesis and then bursting suture and then dissections. This is the first type of the TATME. We know about triangle platform. That's we always use the gel point pass, but now I have 3 generations. As Professor Ramin talked before, the first generation is the second generation, and the third generation come with the insufficient stabilization bag. The second type of the TATME is used for the patient that need to perform the intersphincteric dissection first, and then you can dissect upward about 4 to 5 centimeters and then apply the gel point pass placements and then dissections. Start with the ISR first and then apply the triangle platform and then go to dissections. This is a instrument that we use. The abdominal team use the instrument as perform conventional laparoscopic. But for trianals, we recommend the 0 degree of the 3D camera to use because you can adjust the depth when you perform the laparoscopic surgeries. Use the Lone Star Retactor gel point pass, and the instrument is used, or you can use hook or spatula ties. We need SU system, but if you don't have the SU system, you can use the gel point platform with the insufficient stabilization bags. And when to perform anastomosis, you can use staple hemorrhectomy, circular staple, or depend on the technique that you prefer. And this is one of the very useful instrument is high Q suction irrigations. When you perform trianal, sometimes have some bleedings, but this instrument from Olympus can help you very much. You can suction irrigation, and also the cauterization at the tip is very useful. The SU system is will maintain the pneumopelvis for you when you perform the surgeries. If you do not have the SU system, you can use the third generation with the insufficient stabilization bags, or you can apply by yourself, use the glove. Okay. This is the positions when perform the surgeries. There are 2 teams. Abdominal team have 3 surgeons, and the trianal team have 2 surgeons. The abdominal pass, the post placement as usual when you perform the conventional laparoscopic surgeries. And this is trianal process. Apply the device introduction, marking with cauterizations, and then bursting suture. Maybe above the marking of the line of marking about 1 centimeter, and the marking is about 2 centimeters from the lower border of the tumor. Then start rectotomy full thickness, circumferentially, and then anastomosis. The device introduction, so many styles of the trocar placement in the gel point pass. Professor Lacy's always use camera below, and working part is here, and he sit together with the cameraman. Professor Ito used camera part here, and working channel is below, and the cameraman will stand outside the view between the leg of the patients. And this is another style that you can use. Okay, many styles depend on your preference. And I always use like Professor Ito, and also sometimes I use like this one, sit together with the camera man. This is Professor Ito will sit here, and cameraman will stand here and control the camera, and also control the gel point pass up and down when perform the surgery. From the previous international registry report, There is a famous paper in the year 2016 report from 720 cases. There are 20 cases that have a conversion about TATM is to 0.8%, and there are 4 cases which report failure of bursting and also leakage require a repeat bursting suture again. The excessive smoking of scale about 21.9%. The difficulty maintaining a stable pneumopelvis is 15%. The incorrect pain is 7.8%. Pelvic breathing is about 7%. Visceral organ injury, for example, urethral injuries, also show bladder injury, hypogastric nerve injury, and also rectal tube perforations. The first step that we need to know when we perform TATME is to make a bursting suture is a very important step. The first step of the bursting perform is submucosal layer of the bursting suture. In this video, we will push the gauze below the tumors, and then markings, use the cauterization to marking that we will start dissection from here, and we will perform the bursting suture above these markings. The markings, you can adjust the distal margins of the tumor. This makes the submucosal dissection. We recommend 3D endoscope because you can easy to perform the bursting. This case, I use the needle poly number 20. The length of the curve of the needle is 26 millimeters. And different from the right side video, the needle length is 70 millimeters. This one is sometimes difficult if the pelvis is a little bit tight, but you do not need to do much for stitch. But this one you can move the needle easily, but need to perform more stitch of the bursting. Take a little bit more time than the left side videos. So now you can do single or double bursting, but now I think it's to be safe to use the double bursting because you can secure the tumor cell spillage more than one of the bursting sutures. And another is about the incorrect brains and the complications. The brain, as Professor Ito showed you, that we need to know about anatomy of the pelvis from below. In male, anterior has prostate and pre-prostatic ureters. The neurovascular bundle is located at the 10 and 2 o'clock, and another outside pelvic organs. The same in the female, but in anterior, you need to carefully about the posterior wall of the vagina, but another is the same. This is an organ that's prone to be injury when you perform the TATME. In males anterior, you need to careful about the pre-prostatic ureter, prostate, neurovascular bundle, and the posterior pre-circle vessel. And the lateral is the internal and external iliac vessel. If you go to the long brains outside, it may be injury. There are some reports about the injury of the iliac vessels and the female in the anterior wall vagina, posterior wall vagina. This video shows the upper show the dissection in male. We have to need to know about the warning signs that may be prone to be injury to the urethra. If you dissect the anterior and you see some bleeding or see some flappy patch or striated muscle, that maybe go to the wrong brain. You see right here, these are vessels. And if you dissect and see some bleeding, keep in mind is maybe go to the wrong brains or incorrect brains. And check again. This is a prostate scan. And we need to dissect here. This is a prostate scan. We will dissect around here. This is the correct brains. Why we easy to injury when we perform the anterior pass? Because the positions of the patient will head down and you will be go to the incorrect planes easily in the anterior pass. But in female is, I think it's to be easy to identify the planes than male, because you can check by per vaginal examination when you perform in the anterior part. This is a posterior one. You see, per vaginal examination can check, and you can go to the correct planes. Okay, now some report. This report from Professor Sam Atala. That's in this case, go to the incorrect plane in the anterior part here. The surgeon use a cauterized system here. Let's go two more anteriors that will expose the picture like this. This is a very beautiful picture. But if you see picture like this one, the tube structure here and the vessel here is, you keep in mind that we go to the wrong plane. This one is a pre-prosthetic ureter. The surgeon did not know this is anatomies and use the instrument to cut it. And this here, and this one, prostate scan here, the same picture. And if cut it, you will see in the ureteric catheter inside. And this is very serious complication, because this is happen. You will call your urologist friends to help you. It's very difficult to manage at this part if it have an injury. Okay, I will pass this video. Okay, then when we perform the cadaveric workshop, we need to go to the outside plane like this one to identify. This is the view from cadaveric workshop with Professor Ito. See the prostate scan here and the pre-prosthetic ureters. This is levator ani muscle. In the anterior part, if you cut the endopelvic fascia, you will see the levator ani muscles. Okay, and please keep in mind that TME AP resection is more difficult than TME ISR, and also more difficult than TME conventional. And for the lateral, please keep in mind that the 10 o'clock, you will be exposed to the neurovascular abandon. And if you have bleeding, please carefully track the rectal tube to another side and carefully dissection here. Use the cutting, the same at the left side of the patient. Okay. And sometimes this view from abdominal part, pelvic bleeding was reported in TME case about 6.9% from 720 cases. Means about 50 cases have the pelvic bleeding like this. Okay. Professor Hill showed from this video that the surgeons dissect into the long planes. This is the endopelvic fascia. If you go under the endopelvic fascia, you will see the pre-sulcal venous plexus and maybe cause injury. But in some time we need to go in this plane that, for example, the case that have the T3 lesion, I think we need to go outside the endopubic fascia. And in this case, he go to drop the endopubic fascia below and then go to the correct brains. And if you have some breathing when perform TATME, you can increase the pneumopelvis till 20 millimeters mercury, but is carefully about CO2 embolisms. And in this situation, you can use the bipolar system to stop the breathing. Next, I will talk about anastomotic technique in TATMEs. There are two types. One is hand-suprachoroidal. Another one is use the stapler that divide in use the staple hemorrhoidectomy or conventional stapler that divide into technique abdominal double bursting or trianal double bursting technique. Hemorrhoid stapler and conventional stapler. Hemorrhoid has a little bit size. Please carefully when used. This one is maybe easy to injury to surrounding organ. We'll show you the video. Form report about anastomosis in lab TME and TATME. In lab TME, we know that is a double staple techniques, and for TATME is a single staple techniques. It should be have low rate of the leakage, but from literature report show that very high. Some report from 5 to 25. This is only 4 cases. We cannot count this one. But from the pioneer, Professor Ito showed the leakage rate is about 1.8%. And Professor Lacey showed about 8.6% in his report. And in this literature show the leakage rate is about 6.7%. That early show in the early and about 5.4%, and delay is about 1.3%. From the big study, about 1,594 cases show the leakage also high too. It's about 9.8%, and the total overall anastomotic failure is about 15.7%. So we recommend to perform the ICG with fluorescent endoscope in our case before perform anastomosis. This can reduce the leakage rate from report of the bilateral tubes. So another technique, another first thing that's very important is before anastomosis. You need to perform all layer of the first string suture here. This is a rectal cup. This is all layer of the first string suture. Okay, I will pass to this another video. In another case, I also use poly number 2 zeros. And in this video, you can use or call your partner from the abdominal part to check you that is you make a good bursting outline or not. You see the camera from above to check you again. This is the first type of anastomosis is a hand-suprachoroidal anastomosis. That's the same technique as you perform conventional ISR or laparoscopic ISR. ICG first, and then you will see the cut line here, and then pass the bowel through the anus and check again. And the abdominal team will check that your bowel is not twist, and then perform anastomosis. And after completely suture here, then check again with the ICG. The 3 steps to check of the ICG in this case. And another, in this case, I use hemorrhoidal staple is a little bit big. Use carefully when used it because it's easy to injury to surrounding organ. In this case, I perform busting directly, not use the laparoscopic, just use the camera inside here. This is a distal busting. And then we get the proximal colon here and make a bursting suture again here. And then use the end view to apply. This is the long shaft of the end view. Okay. After that, you can push this one into the platform here. And then tie the bus strings. Then you can apply the circular stapler here. This side is a little bit bigger than the embroidered stapler, but you can remove this one first and then perform this one, or you can do like this one. Okay. And after that, check with the ICG again to check that your anastomosis is good but supply or not. Okay. And this that now that I always use this technique by Professor Ito to perform the anastomosis. This is called transabdominal double bursting suture techniques. That's suitable for long stump of the rectal cup here. After completely bursting suture, use a thoracic tubes number 9 or number 10 to insert in the middle part and tie the burstings. And then use it to guide the circular stapler into the anus. And your team from the abdominal part will remove and guide you to put in to the middle. And then remove and then perform anastomosis like your conventional laparoscopic technique. Check your bowel again does not twist. And after complete anastomosis, you will check again with the ICG. Okay. And the last type of the anastomosis is for a little bit short of rectal cup here. Make a bursting suture and then the abdominal team will pass you the thoracic tube and end view and also proximal bowel here. And you grab the end view, the tip, the shaft of the end view here, and then tie the purse string and then apply the circular stapler. There are two types of the anastomosis, handsaw and stapler, but stapler will divide in 3. And the last, after completely anastomosis, we recommend to reinforce sutures. PDS number 40 is about 16 stitch here. Like technique of Professor Masaki Ito. We also learn from him that it's very useful to make sure that your nasal will be good. Okay, I will pass this video. And from the same report from the Norwegian study is very rapid recurrence in their case, and also the pattern of recurrence will very uncommon. Lateral compartment of pelvic recurrence, and if you see in the papers, 7 of cases of the recurrence intraoperative rectal perforation. That may be because of the tumor recurrence here. And I told you that the bursting suture is very important in the first step. If the bursting is not good, when performed, if you have some serrate from here, when you use the ACL, the flow of the ACL will push the tumor cell to the lateral. That is maybe cause of the recurrence to the lateral pelvic sidewall. Okay, ladies and gentlemen, for my conclusions. So I think what should we know about TATME? That's first the indications, anatomies, and the technique and complication and management. You need to learn this one. And this my select case nowadays. If the patient have to be a difficult case, I will select TATME first for middle and lower rectal cancer. But if you do not have the team for TATME, you can try the conventional lab first. Or in not difficult case, you can try TATME if you have 2 teams. But if you do not have, you can perform with conventional lab. Okay. And the near future, I think the robotic TATME will have role in this situation. You know, the MESDA was approved by FDA in the year 2019. It's very useful to try to perform the TATME in the future. And also many reports in cadaveric models. And I think robotic Da Vinci SP will have a role in the TATME in the future. And you will see some live demonstration with the robotic plus TATME, or in the future robotic plus robotic Da Vinci SP together, 2 robotic in one case. Thank you very much for your attention. Okay, we go to the next topics about the laparoscopic APEs by Dr. Sripong from Songkla Hospitals, Prince of Songkla University. He will talk. He's the chief of the minimal invasive surgery unit of Prince of Songkla University. Very please welcome Professor Sripong, please. Thank you.
Good afternoon, everybody. So do you hear me? Dr. Pawit, do you hear me?
Yes.
Okay. So first of all, I would like to thank Dr. Vitun and Dr. Pawit and all of MESDA committee to let me have the opportunity to be here today and say hi to our Japanese friend, Professor Kitano and Professor Ito. And congratulations to the new robot, the new platform, the robot. So I hope to see all of us as soon as possible after the COVID resolve. So my topic today is about the laparoscopic abdominal perineal resection. So I will be brief and concentrate on some potential hazard and some technical issue during surgery So as well as the strategy to avoid the honing down specimen, which can result in the perforation of and poor outcome. Okay, so my slides, usually I have no financial disclosure or conflict. So we now have many options for treating the distal rectal cancer, like you see here. So many of speakers today we heard a lot of TA, TME, lab ISR, the beautiful outer lobe anterior, but we still have a tumor that has spread to the sphincter, and we were unable to perform the sphincter saving procedure. So that's why the AP resection is still needed to learn. Okay. So back into the 10 years later, there have been numerous publications in last, I think about 10 years, describing about the poor outcomes of the conventional AP resection. So this concern raised the question of the procedure that benefit from the radical resection. So when compared to the low anterior resection or anterior resection, the outcome of the AP resection is poorer. This caused the AP technical to be revisited, and the concept of the extra-elevator or cylindrical AP resection then emerging. So at that time, this concept of extra-elevator spread to the community of the colorectal surgeon. But now, 10 years later, in reality, I think nothing is particularly novel now. If we understand the anatomy and particularly on the tapering of the mesorectal in relation with the pelvic floor. So the idea is, I think, simple as the en bloc resection. Okay, so why do we need the extra-elevator APE? The reason for this maneuver is that the most of the publication mentioned the majority of the poor result were caused by the inadvertent intraoperative bowel perforation or lack of concern about the surgical technique. So the question is that what is the cause of a higher positive margin in this more or this aggressive surgery? So the answer, I think, should be answered through the specimen or through the perspective of the anatomy. So when we looking back to the anatomy, this can help us answer this question. So we begin with the specimen examinations. So rectal cancer surgery, as we all know, I think it is a highly technical, demanding procedure, and the specimen can tell us about the surgical quality. So what is so different between the left side and the right side specimen? They both have a very nice plane of TME and very nice plane of the posterior margin or circumferential margin, except the left side. The picture in the left side has the waist or the holding down fashion, contrary to the right side specimen. It is in the cylindrical shape, and it has the coccyx here and the levator envelope, the tumor. So let's zoom in. You can see that the specimen has the waist, and if the tumor sits here, the circumferential margin maybe is not good. It's not like in the right side. The tumor is covered nicely with the levator muscle. So on the section, you will see clearly the tumor sit here with the levator cover the tumor. So this is the concept of the en bloc resection. We all know, all of the surgeon knows that in order to get a good margin or good circumferential margin, you have to have something to cover the tumor. Okay, so the first point I would like to mention you is you have to avoid the coning down specimen. So in order to do that, you need to know the perspective of anatomy when you do a extra-elevator APE. If you are intended to do the the APE resection, like you do a lower anterior resection, like this, you will get the perforation or unintentional perforation or something positive circumferential margin. So to avoid the perforation, so you need a little bit margin by excise the levator with the specimen. So the next thing I would like to mention is that the technical problem occurring during the APR or AP resection. First thing is the anatomy of the tapering mesorectum and poor visibility from narrowing pelvic space, and visualization of post-scan is very limited from above. Okay, as you see in this image, you see the point of the end of the mesorectum here. If the tumor is sit here, and you intend to do the AP resection like you do a lower GL resection, of course you can get a beautiful pair like this, but at the anorectal junction, you can make a tumor perforation. So again, in this picture, if you follow your nice plane in TAB and you're not concerned about the tumor here, you may dig into the tumor and make a perforation. So if you know it before surgery, or you plan it before surgery by seeing the MRI, you have to plan to excise something, cover the tumor as displayed. Okay, for better understand, I have a real footage here. This is anatomy of the lower anterior footage. Okay. The rectal anal angle is here, is fully exposed before apply the stapling. So this is nothing here apart from the rectal tube. There's no mesorectal at all, just and bare rectum. And if you intend to perform lower anterior with dissection the mesorectum of the pelvic floor, but the tumor is sitting here, you will enter the perforation or positive circumferential margin. Okay, so again, so be careful when you do physical examination and you found that the tumor is at the anorectal junction, or you can evaluate before by the MRI. If you see the picture like this, you see the tumor is near the levator and line. That's just less your concern about the margin, the circumferential margin. Again, see? So I think the MRI is required to determine the exact location of the tumor. If the tumor is near or located very closely to the levator, surgeon should keep in mind concern about the possibility of unintentional perforation. Okay, so now 10 years later, so let us look at the most recent evidence from the reviews. So the measure of the evidence for meta-analysis or from systematic reviews tell us that the measure of the evidence indicate the decrease in the perforation rate in laparoscopic extra levator, and some author reports that improve the circumferential margin with the extended levator and improve local recurrence. But unfortunately, you must concern about the wound complication and morbidity as a result of a large perineal defect. So you have to trade off between the improved circumferential margin and the wound complication. Okay, so this graph again reveals you the important message from the study that compare between the conventional and the extra levator APE. Both conventional and extra levator are slightly different in disease-free survival, and neither provide the survival benefit. The survival benefit is a little bit different and non-significant. So pitfall and potential complication of the extra elevator is 1. Inadvertent perforation, 2. Neurovascular bundle injury during the anterior dissection, and 3. As the previous speaker, Dr. Pawit and Dr. Ito mentioned, STA-TME, we have a report of some urethral injury in prone position. Okay, so the technical you need to learn is that when to stop to do the abdominal phase and turn to do a perineal phase. So you have to stop the abdominal phase at the levator level, at the coccyx level, I think, and just below the seminal vesicle in anterior, and then turn the patient to the prone position to do a pelvic dissection. Like in this picture, you stop the dissection just below the seminal vesicle anterior, and in the lateral you stop at the neurovascular bundle, and then for the posterior you stop at the level of the coccyx. But I think, however, the surgeon should plan precisely, I think, on the MRI at the location, the exact location point to stop the abdominal phase, because it depends on the tumor extension. So here is a short video to demonstrate you when to stop the abdominal dissection. Okay. Okay, this is the line of the dissection. The tumor is at the anorectal junction here. This is a quite beautiful posterior plane of the mesorectum. So the posterior dissection should be stopped at the coccyx level here. Do not dissect the posterior mesorectum from the levator. That leaf is attached to the tumor. Okay, this is the anterior. You just stop at just below the seminal vesicle. And this is a lateral dissection. This is a neurovascular bundle. So after you dissect the lateral dissection like this, you have to stop and then turn to the perineal phase. Okay. This is a seminal vesicle, and as you see here is the vena fracture. Yeah. For the abdominal phase is quite already. So this video is in a female patient. We try to demonstrate the extra elevator fashion. So I think not every case is necessary to require last excision, because just tailor the margin by the MRI before you plan, before you do a surgery. Not do a wide incision of the skin, because it is not a skin tumor, right? So after you cut the coccyx like this, you can insert your finger and tailor how wide is you want it from your tumor. So you can tailor the margin of the levator and try to avoid unnecessary excision. Okay. So in this case, we leave some part of the levator that we can close the defect to prevent the perineal hernia. So not all the cases need the extra levator like the wide excision. So you can tailor it by the MRI and plan before you do a surgery. Okay.
This is a thing I need to mention you because when we do AP resection in this position, it is quite strange for us because this is an unfamiliar anatomy to most of the surgeons that coming from above or do a low anterior dissection from above or do a prone position AP dissection. So thing you need to concern is that you may injury the ureter at this point. Here, as the Dr. Ito mentioned, the important landmark is the recto-urethral muscle. Try to identify this structure before you dissection in the anterior margin. You can be avoided by the palpate the urethra or use the ICT like Professor Ito said, or use the AI system that I think it is very nice machine learning or AI presented by Dr. Ito. Okay. So this short video demonstrates you to understand the important anatomy why you do lap excelerator. This comes from the Indian doctor in YouTube. So here you flip the specimen out and you can see a really beautiful seminal vesicle. Here is the important point. You need to concern the urethra when you cut the recto-urethral muscle. And then you see the beautiful seminal vesicle here. You see a process there. Yes, it's process, and you see nerve here. Neurovascular bundle or plexus here. Okay. Okay, now there are several types of the AP dissection. It depends on, I think it depends on the tumor extension. The ichinoanal excision is reserved for the very locally advanced tumor that extend to the ichinoanal fossa, the accelerator APE, and the interspheric AP dissection. This is for the benign lesion only thing. For the such as for the Crohn's disease, with the patient have the anal incontinence, so we can do the interspheric AP dissection. But there's the new procedure that I would like to mention to you. I just read it a few weeks ago. That they call this article is from the Theodoros doctor from Greece. So this is a sphincter saving procedure. You'll be amazing that it can be sphincter saving. They call the hemi-elevator excision. The idea is that if tumor is sit in the right side, they do an accelerator excision and then go back to interspheric resection like this. For the left, they do like a low anterior resection and then resect specimens and do a coloanal anastomosis. But I'm curious about the anal function, but they said that they claim that the anal function is not quite bad. So this is, I think, the half blood, like a low anterior resection and the extra elevator combined. So in order to do a sphincter saving procedure, it's quite new, I think, and I think it's quite interesting. A little bit difficult to do, I think. It's not quite easy. Okay, this is a specimen for different type of the AP dissection. This is the old paradigm, the cylindrical here, the old west specimen of holding down specimen here, the nice cylindrical with the coccyx here. The reason why we need to cut the coccyx because we can get more room. When you cut the coccyx out, you get a bigger space, and then you can customize the levator cutting according to your tumor extension. And on the right side, you see the ichinoanal excision specimen here, reserved for the bigger extension of locally advanced tumor. like in this patient, after CCRT, she still have a very extensive tumor like this, involving the posterior vaginal wall and have a fistula like this. So we have to do the ischio-adult AP dissection and do a reconstruction with posterior vaginal wall with a gastric flap like this. You can see the specimen is 9 strain of TME, and then we have to cut the levator. In this case, we cut the levator at the origin near the obturator membrane. And then we have to do a very wide skin excision, and also as a nearly total of the ischio-anal fat with the specimen out, and reconstruction with the flap. And then we get this like this picture. This is a follow-up, I think 1 year later. There are no recurrence. Actually, I am not a big fan of the aggressive tumor like this. I think Chulalongkorn University, Dr. Chushib and Dr. Songpon do it very well and very fantastic. If you like more aggressive surgery like this, you have to watch the lecture of the ELSA that Dr. Songpon mentioned, the sarclectomy or the accentuation, where the minimal invasive approach. It is quite nice lecture. So in conclusion, I think finally the extra levator concept is nothing more than the principle of the en bloc resection. To improve your circumferential margin and reduce the local recurrence. But however, it is not yet seen the benefit in terms of the overall survival. So you think you need to do is to recognize the different anatomy before and decide the operation with the preoperative MRI. And you have to avoid the ureteral injury, because in this area, the unfamiliar anatomy can result in the damage of the ureter. And last, you have to trade off between the wide excision and the reconstruction and wound morbidity. So that's all my talk. Thank you so much.
Thank you very much, Professor Sripong. It's very fantastic. Slides. So we go to the last topics. Will present by Associate Professor Attapon Tatansingha. He is a surgeon from the Minimal Invasive Surgery Unit Department of the Surgery Faculty of Medicine, Sirat Hospital. Today, Professor Attapon will give us a lecture in the topic of total neoadjuvant therapy in MIS rectal cancer surgeries, the experience challenge. Professor Attapon, please.
Thank you very much, Professor Pawit, for your kind introduction and your kind invitation. Nat, could you share my slide? I'm so sorry because I got the technical problem to my computers, and now I cannot share my slide by myself. I have nothing to disclose. For the locally advanced rectal cancer, we all know that the preoperative treatment of radiation and chemotherapy is beneficial for locally advanced rectal cancer. Dutch TME trial is one of the landmark study. They already published the 10-year local recurrence is not significant different between is significant different in the short-cut RT followed by TME group. And for the preoperative short-cut RT is significantly have a beneficial effect to the negative circumferential margin group and also the stage 3 cancer. Thank you, please. For long course neoadjuvant chemoradiation, the 10-year local recurrence is still significantly lower in preoperative CCRT group. If you remember, the 5-year local recurrence is 6% in surgery alone group and in long course CCRT and 11% in the surgery alone group. But for 10-year, the result is 7% in CCRT group and 10% in the surgery alone group. That is still significant difference. Whereas the overall survival is the same. And for Stockholm 3 trial, they compare classical short course RT means you give them the patient 5K by 5 days, and after that you surgery on the next week follow. And compare to the short course RT with the delayed surgery, and compare to the long course CCRT. The result demonstrate that there are no significant difference in terms of overall survival, local recurrence, distant metastasis, and complication. However, if you go to compare only the short course, classical short course RT and short course RT with delayed surgery, the complication is significantly higher in the classical short course RT group. For the delayed surgery, we imply the data from Dutch TME trial. The maximal response of the radiation is about the 10 to 11 weeks after completion of the radiation. And that is the highest chance of the PCR pathological complete response. After this point, the effect of the radiation seem to be plateau, means you not get the more PCR rate after this point. Therefore, I think nowadays all of us perform the surgery after the completion of radiation about 10 to 12 weeks. This is the data that we imply from the Dutch TME trials. The worst benefit. The worst, there is disadvantage of prolonged surgery time between the completion of radiation to surgery can cause a technical difficulty because of if you wait more, the fibrosis formation may getting more than if you operate quicker. And you may increase the risk of wound complication and also the synchronous metastasis. Why was that? I'm gonna show to the next slides. This is the usual that we operate. Usually, back to the old day, you give the patient with the long course CCRT, mean the patient receive 50 to 54 gray of radiation that gonna occur in about 5 weeks. And after that, you will wait 6 to 8 weeks and operate the patient. And after that, about 4 to 6 weeks, you give adjuvant chemotherapy to the patient. But nowadays, the practice is you give the long course CCRT to the patient. And after that, you wait a little bit longer to 10 to 12 weeks. And after that, you do surgery. 4 to 6 weeks after that, you give them the adjuvant chemotherapy. That means the patient wait about 19 to 21 weeks after completion of the CCRT to receive the systemic dose of chemotherapy. Therefore, the long-term survival has remained unchanged. If you still do the practice just like the classical approach. And also the distant metastasis are now the leading cause of death. It's not the local recurrence. Because if you wait too long to give the systemic chemo to the patient, we're gonna fail with the distant metastasis. Next, please. And this, the new concept of the total neoadjuvant therapy, it means to delivery of full dose chemotherapy a little bit earlier. In addition to standard neoadjuvant chemo radiation before definite surgery, we divided to 2 terms of TNT. The first is induction chemotherapy. We give first with the neoadjuvant chemotherapy, followed by the neoadjuvant chemoradiation, and after that we do the surgery. And the next term is consolidation, means you give the conventional neoadjuvant chemoradiotherapy, followed by the neoadjuvant chemotherapy, and followed by surgery. We call consolidation. And for the benefit of the TNT, means you can give them early chemotherapy systemic dose to target the subclinical micrometastasis, and also to improve the compliance rate of chemotherapy. We all surgeons, we have some experience that some patients cannot recover well after you pass the chemoradiation, you pass the surgery, and after that they cannot tolerate the chemotherapy. If you move the chemotherapy early to surgery, they may have more to improve compliance rate to chemotherapy more than if you give to the adjuvant dose. And the next thing is you can assess the tumor biology, because you still have something to measure. If you give them you treat the micrometastasis disease, when you have already removed the tumor from the patient, we cannot measure our treatment, because you step forward with the adjuvant chemotherapy. You cannot have something to measure that this tumor had a response to the chemotherapy that we give or not. And the next thing is you can potentially increase the R0 resection, or you get the more rate of the PCR. And for this era, if the patient had a clinical complete response, some patient may candidate for the watch and wait protocol. The next is our experience. After this is I'm gonna show you our experience of the TNT at SIRAT Hospital by our unit. We do the retrospective review from prospective maintained database from 2016 to 21 at MIS unit SIRAT Hospital. We really selected patient to do this protocol, because back to around 2016, 17 or something like that, the main problem of doing the consolidation cases is the reimbursement. At that time, we cannot give the FOLFOX or CELOC to the patient without pay. The government pay only if you give the oxaliplatin as the adjuvant therapy, not the consolidation chemotherapy. Therefore, we really selected patients to receive this treatment, because all of these patients need to pay by themselves. The government is not coverage the cost of the oxaliplatin. But today is good news that the oxaliplatin is already approved to give as a consolidation. Therefore, nowadays we don't have the problem of the reimbursement issue. We enroll 20 cases. All of these cases, 4 cases is induction or upfront chemotherapy, and 16 is a consolidation. Next, please. And the mean age of patient is 60 years, and vary from 40s to 80 years, and majority is a male. And the median distance from anal verge is about 5 centimeters, vary from 2 to 8 centimeters. Majority of the patient is a lower rectum. And this is I think I choose this topic to this conference because for all of us in this area, we cope with the same situation. We cannot imply the data from Western country or from developed countries to our developing countries. We still, all of our practice still cope with the big bulky tumor, impending obstruction, and this is a real life situation. And similar to this study, about 6 cases or 30% of the case, we need to have a preoperative diversion before we perform the surgery, before we start the chemotherapy or chemoradiation, because the tumor is too big and the patient already have some part of the obstructive symptom. And for the neoadjuvant chemoradiation, the dose majority is 55K, means you cope with a very locally advanced. Usually, the dose of the the radiation that radiotherapist give to the patient is 50.4K. But all of the locally advanced case that the tumor is quite big or you have a lot of nodal disease, they're gonna give 54, similar to the dose of the anal cancer. Next, please. And chemotherapy regimen majority is oral capecitabine compared to the infusional 5FU. This is not similar to the Western country. I know that some center in Thailand, they do the PROTAC 5FU, but majority of us still do only infusional 5FU, means you give them only the 4 days of 5FU infusional and 4 days before the radiation stop. We call this is a Mayo regimen. They already have the study that proves that oral capecitabine similar to the PROTAC 5FU and better than infusional 5FU. Therefore, usually we use the oral capecitabine more than the infusional 5FU for the preoperative chemotherapy regimen. Next, please. And this is our data after completion of the radiation. The median time of restaging MRI is 60 days, vary from about 23 to 150. This caused by the problem of the COVID outbreak situation, and therefore some patients got the problem of to getting the MRI after the treatment. And this is the clinical T-state, end-state, and margin from restaging MRI. You will see that the majority of the patient is clinical T3 by the restaging MRI, and also the nodal disease and treated CIM. Therefore, this is not the good candidate case to operate the patient at that time. And also we use the EMBI and also the TRG grading system to determine this patient should step forward for surgery or should receive the consolidation chemotherapy. Next, please. And systemic chemotherapy that we give as a consolidation majority is a CELOC regimen, means you get the oral capecitabine combined with the oxaliplatin, and about 1/3 is a FOLFOX regimen. Next, please. And median time from completion of the radiation to surgery is about 240 days. Mean the surgery is occur about 8 to 9 months after completion of the radiation, and you have a surgery at that time. This may cause the question for all of you that can we operate easily in this kind of the case, because we wait very long time. Usually we operate only 3 months after completion of the radiation, but all of this case we operate about 8 to 9 months after completion of the radiation. You will see the laparoscopic surgery is still operate to this patient is feasible because we do open surgery about 40%, but if you remember the number that I mentioned to you, 30% of these cases already have a preoperative diversion. And I have a problem about this case that I cannot perform laparoscopic surgery when the patient already have divert because of I tried, but it's not work for me. But after my talk, maybe some other surgeon can discuss to this topic. If you can operate in the laparoscopic approach, I would like to learn from you. And for the operation, majority is APR because the tumor is quite low, and for THME is about 30% of the case, and low anterior is about 15%. Next, please. And the complication occur in two cases. First one, the one is ostomy necrosis, and the second one is post-operative bleeding that need to be reoperated. But we cannot find the bleeding point, just only oozing, and we just stop bleeding, and the bleeding stop. And the pathological result is quite, surprising. Surprised me because we got the YPT0N0 mean the patient had pathological complete response is about 1/3 of the patient. This is you remember this is the case that had poor MRI restaging factors that we did not perform surgery at 10 to 12 weeks as usual. We give them the consolidation chemotherapy and wait to 8 to 9 months. And we get like 30% of the pathological complete response. And more than that, 25% is only stage 1, YPT2N0. And 25% is a YPT3N0. And only about 20% is stage 3. And all of this case that I learned from this study, for the tumor, the biology of the tumor, that if you already give them the neoadjuvant chemoradiation, and the tumor is not respond to the chemoradiation, you give them the full dose of systemic chemotherapy, and tumor is still not respond from the systemic chemotherapy. You don't have anything to give them, and you decided to operate on this patient. I'm gonna tell you that the sad story is the surgery that you perform is not help the patient at all, because from our study, the distant metastasis is occur very, very fast for the tumor that have resist to the CCRT and the full dose systemic treatment. Because from the study, if one patient had a YPT3N2, and only 4 months after surgery, he developed the lung metastasis. That the CT before we do the surgery did not identify this lung metastasis. And for one third of this YPT1 and T3N1 developed the distant metastasis at 6 months. This is a very sad story. And next is what do we learn from this result? First is the PCR rate is 30% in TNT group. As I mentioned from beginning, that TNT may potentially cause you the higher rates of PCR, because if you go back to the standard study before, majority of the patient has a PCR rate about 15 to 20%. But from this study, we have a PCR rate about 30% is quite higher than the usual treatment. And especially this is an initial poor response NCCRT cases. And the next is laparoscopic surgery is feasible. As I mentioned to you, 60% that we can successfully perform in laparoscopic approach, 40% that we perform open surgery, 75% of open surgery cases already have a diversion. Therefore, we did not try the laparoscopic surgery in that situation. And the next please. And complication is acceptable. 2 in 20 cases is about 10% compared to our previous study that we already report. About 11.7% in the surgery within the 8 weeks after completion of radiation to surgery. And for the more than 8 weeks, we have a complication about 18.6%. The problem is a different time of the study because this is a recent study that we have 10% compared to several years ago. That I mean, the number of the cases that we do the surgery is like you have more experience. The complication may different, and to that time, or you have a more updated instrument to help you to perform the surgery safely. And the last one is in poor response patient, as I mentioned, surgery has no benefit on oncological outcomes. In that particular kind of patients, I think the additional chemotherapy or combined with the targeted therapy or immunotherapy may be the ways to go. Should not be surgery, as I mentioned before. Next, please. Thank you very much for your kind attention.
Thank you very much, Dr. Atapon, for your excellent lectures, and so very nice result. Completely a pathologic response 30%. Very impressive. So we gone to the session of Q&A. So could you please share the video of the speaker? Can you manage all the speaker in the same view? Okay. So okay, so we have the question from the front to Professor Supakit. The question is why the biopsies and tattoo to the specimen are abandoned.
Okay, thank you. It's because of when you do the biopsy, usually have the scarring or the fibrosis happen to the lesion, and it's more difficult for the dissection by the endoscopic treatment. So that's why we just need only the photo and no need for the biopsy. And also with the tattooing, because when you do the tattooing, usually you tattoo into the submucosal layer, and the dye is spreading all around, not just the point that you put the dye in. So sometimes is when you do tattooing close to the lesion, it spread into the lesion. So when we do the dissection, so submucosal layer is very difficult to distinguish from the dye or the tattooing color. So that's more make us for more difficult to do the endoscopic treatment. So just take the photo is okay.
Okay, thank you very much. So only one question. And your speaker have any question? You can ask together.
Can I ask Professor Masaki Ito?
Yes.
Your robotic system is quite impressive. And then can I ask, is this have a chance to available in the market soon? I mean, available for the other country to buy, purchase, or something?
Yes, of course. So now we are applying to the government to permit this robotic uses in Japan. And maybe beginning of next year, maybe January or February, government will permit to use this robotic system in Japan. And maybe, so our parents' company is very big company. So Asahi Intech, maybe you don't know the name of the company. So Asahi Intech is very big. And also that they have the very many company is all over the world. I don't know the Thailand, I don't know, but maybe so several years later, you can see our robotic system. So our robotic system is entirely different. Concept is a little bit different from the Da Vinci system. So Da Vinci system is operator is sitting the remote from the patient, but my robotic system is operator is standing seated along the patient, and the operator perform their own laparoscopic surgery. And the operator's right hand and the right foot pedal is control the 3 arms of robotic system. So only one operator can operate the 3 surgeons operate laparoscopic surgery. You understand?
Yeah.
Right?
This means like the surgeon have more than 2 arms.
Yes. One scope and the 2 arms.
Yes.
So let's one additional arm compared to the Da Vinci system. Maybe Da Vinci is assistant had only 1 arms, and in Japan, most of the hospital is surgeon is assistant sitting along the patient and support by use of the usual laparoscopic devices for the operator. So maybe, so if you use our robotic system, maybe only 1 solo surgery will be done.
I see. So how about the price? It's better than the Da Vinci?
It's actually the secret now, but about 8 times less than Da Vinci system.
Wow.
Yes.
That's really good news for us.
Yes. Very price is very good news for you.
Yeah. We do know the Asahi companies, but only for the beer. And then
yes, but Asahi Intech is very focusing the catheter, the radiological catheter. The share is maybe the number 1 all over the world, but the surgeon, most of the surgeons do not know the name of the Asahi Intech.
I see. Thank you very much.
Yeah, thank you.
Right, Professor Ito.
Yes,
Yeah,
Professor Bitun.
I have to congratulations for your successful in answer a robotic platform. I remember 4 or 5 years ago when we visit your center.
Yeah.
I saw only 1 single hand of your robot, single arm.
Yeah.
Now you got 3 arms already.
Yes.
I think gonna be very successful in the future.
Thank you very much.
Thank you.
So, Professor Bitun, can I ask you 1 question? So in Japan, is a robotic system is going north. So recently the very many more correctional surgeons now perform with the robotic system, especially the XI system. Very good system, I understand. but the reimbursement is same as the laparoscopic surgery. So more robotic surgery is cost hospital not pay. So that this is one of the problem in Japan. So please show me the how about Thailand current status of the number of the robotic surgery, especially for the colorectal surgery, colorectal cancer.
Right. I think so far we have 7 robotic machine. I mean, including the Da Vinci Si and Xi, right? Mm-hmm. And for the reimbursement system in Thailand, we do not get any reimbursement yet. The patient have to pay by themselves.
Yeah.
At the moment, I think many institutes, including my institute, just setting some funding, to support, to pay some expense on top for patient to make the procedure available, right? So that's the way we do it in Thailand.
Right. Thank you very much. Very similar situation in Japan now.
Any more questions, Professor Bovit?
Yes, we have a question from Professor Warabut. The question is, what is the role of the ICG for rectal cancer surgery? Do we rarely need it? In your opinion, Professor Ito?
Pardon? Sorry.
What about the ICG and fluorescent endoscope? Is it really
yes.
for surgery?
Definitely good. So no doubt, very, very good. So if as for our institute, all cases in performing the rectal cancer, so always we evaluate blood perfusion in oral colon by fluorescent scope after injecting the ICG. So all cases. So because after applying such a system with the ICG system, leakage rate is 12% to 3%, reducing. So I think the ICG is definitely the very good tool to reducing the anosmotic leakage.
Professor Ito, warming.
Warming.
Can you mention or criticize about the Pilates trial? That the result of the ICT is not, so promising.
Pillar 2.
Pillar 3.
3 randomized trial.
Yeah, in rectal cancer.
Maybe I heard this trial stop. No,
it's published already, but it's closed before reach the number of the patients, and the result published is not different between using ICT or conventional, not using the ICT.
Oh, really?
Yeah. So, but I think many surgeons mention about, as you mentioned, that the trial course before they reach a number of the patients.
So, my opinion is so lightning checking the by our eyes is definitely very clear. So, in terms of the blood perfusion, so definitely the ICG system is very good one, is my opinion.
I agree with you. Recently, I also use ICT. I think, especially in the patient who is obese.
Yes.
Because when decide to cut the marginal artery in the thin patient below BMI is not difficult, and we can see the bleeding really clearly. But in obese patient, sometimes it's difficult.
But yes, okay. But there is one problem for the obese patient. Their belly arteries are sclerotic, and or some patient had diabetic mellitus (DM). So such a patient is sometimes lightning is very weak. So the sometimes obese patient is not clearly identifies blood perfusion, even if we use such a system. So this is our experience for the obese patient.
So we have another questions from Professor Nopdanai to Professor Attapon. In your opinions, any kind of rectal cancer patient that you offer TNT as first choice of treatment?
Yes, thank you very much, Professor Domnatai, for your questions. Usually, I use for the case that is more. I think this is a more systemic than local disease. For example, like a bulky nodal disease. If you cope with the patient that start with massive nodal disease, this case should start with the induction chemotherapy before the CCRT. And in our study, we do the induction chemotherapy in the lesion that are questionable of distant metastasis, like liver or lung metastasis. We start with the induction chemotherapy, and after that, we reevaluate the lesion again. Therefore, induction is good for the disease is more systemic than the local disease.
I would like to add a little bit about TNT to Dr. Attapon. I think another approach is also very interesting, especially during the COVID-19 pandemic. I have experience to try to use the consolidation chemotherapy, TNT, with after we give the 5x5 RT. That is a similar protocol of Lapidotide. I think it's very useful because patients have to visit during the RT only 5 days instead of 25 days or 30 days in long course CCRT. And the response is quite good in my experience. Probably next time I can share the result with you. And I think it's suitable for our country. That's the problem is the wasting rate of the RT. So it will be benefit. That is my opinion.
And can I ask one question for Professor Attapon about the field of the operation when after you completely TNT and perform the surgery? What about the adhesions or intraoperatively is too much or not?
Yeah. For my experience, depends on the response of the tumor. In the very good response case, the surgery is a little bit different from usual case. But for the case that the tumor is not respond well to the systemic treatment, the surgery is a little bit, not a little bit, it's very, very difficult compared to the usual case. I'm not know why, but this is my observation. Because of the timing is not different between the good response case and the poor response case, but the operative field is totally different between those two groups. Yeah.
Professor Ito, may I ask you the question about the TATME?
Yes.
As you show us the result from the Norwegian country is not so good for the TATME. I think because I think the learning or training system for the surgeon who would like to perform TATME is very important. How about in Japan? Do you have any guideline or recommendation for the training for the TATME like from JSS, similar to the JSS laparoscopic surgery assessment skill? Can you mention about that?
Actually, we have no guideline about the training or the some mentoring system before starting the TATME in Japan now. But actually, we have very little opportunity to perform a cadaveric training course in Japan. So, but and also under very current status of COVID-19, so a doctor cannot see to the visit to another hospital now. So in the current situation, you know that in our institute, we have the dry simulator training system. So which was inventing the dry simulator named EatoBox. So very similar to the human body, human pelvic organ. So, but the next month, we will start the dry box and the live surgery training course of TATME. So actually, later, sooner, so we need to decide some guideline before starting TATME. But so in a meeting conference, so I repeatedly say to the doctors, please start from the easy case and female T1, T2 female. So don't start T3 or male case. So that easy case is a better guideline to start the TATME in safe manner.
Thank you. I think if the COVID-19 pandemic subside, we probably can cooperate, to make this kind of the training. So I think you can remember 2 years ago, Dr. Pawit, in Chiang Mai,
Yes.
Dr. Pawit set up the TATME cadaveric workshop. I think probably you can make the guideline and we can ask Professor Kitano and Professor Vitun to, for the MESDA to set up the training. I think last time in Chiang Mai, we have only chance of the cadaveric. But I think dry box like your EatoBox is very important for practice the pursing suture first, because, we should practice the suture that you show us in the dry box first, then go to the cadaver.
Yes. So watching operation performed by expert is the first step. Second one is train the parsing suture repeatedly, and the third one is dry box like EatoBox. So and also learning curve in TATME is to be set about 40 cases recently. So maybe Netherlands trial showed that they mentoring till the 10 experience, but their local recurrence rate is about 10%. So I think that 10 experiences lack on the way to the learning curve. So 40 case is mandatory. Very safe experience is very important. So expert, if they can expertise till the 40 cases is a very important, I think.
Oh, okay. I hope to see the training guideline coming from you soon, so we can cooperate.
I hope.
So this time we're coming to Hat Yai also to Songkla.
Yeah.
Professor Ito, can I ask you some more question?
Yeah.
Yes, I saw your AI for detect the urethral. Is that gonna be like incorporate in your robot or not? The AI system.
Yes. Currently, no. Because separate team is inventing a new system. One team is AI, another one is a robot. So, but AI is one of the promising tool to avoid such a intraoperative complication. So I think that we focus mainly to the identification of ureter or the IMA or the more very easy cases. So the TATV to detect the urethra is a very difficult question. So the actually the AI team is currently as a first step ureter to avoid the injury of ureter in a laparoscopic sigmoidectomy or rhodontal resection is a first step, and second one is hypogastric nerve. Nerve is also the very we could identify the hypogastric nerve by AI deep learning system. So TATV actually a little bit difficult question.
Thank you.
Thank you, Siripom.
Okay, thank you very much. So I think this time has and I will invite Professor Vitun to.
Right. Okay. First of all, I would like to thank Professor Pavit and his organizing team. And I would like to express my appreciation for his effort to orchestrate just such a beautiful and useful series of lectures to combat rectal cancer. Yeah. After I listening all lectures from nice speakers, something just coming to my mind. If I want to be able to do ESD like Professor Supakit, to do TATME like Professor Ito and Pravit, to do intersphincteric resection and all things, including the knowledge of the chemoradiation like Professor Atapon, how long I need to spend for learning. Perhaps overall of my life, 100 years or something. That means we cannot stay alone. We cannot work alone anymore. So we need to make our team, we need to set up our network or connection and to know how to send the proper patient to someone we know that they're gonna look after the patient the best, or the most difficult case that you cannot do that, right? And on behalf of the MESDA, I would like to commit that this first meeting, webinar, just after we stopped for quite a while due to a pandemic of COVID-19. And this is just the beginning. We are still preparing another 3 webinars, including the hands-on workshop if possible on the way. For example, in November 13 this year, we're gonna have a morning section of the smart surgeons, smart exposure, leading by Professor Siripong and Professor Nini in the near future. And another 2 like 18 MESDA upper GI workshop by Professor Suthep. And also the trainer sometime at the end or the beginning of next year to guarantee that we gonna convey the best thing to our member of MESDA, right? And finally, I would like to thank Professor Kitano, Professor Ito, Professor Bovit and his organization team, all speakers and the participants, either member or non-member of MESDA. They're approaching nearly 200 participants at the top, at the middle of the meeting, right? And above all, we like to thank our long-term friend and sponsor, Olympus and Medtronic, that supports us for a long time. So far, we approaching the 5th year of the MESDA that we organize a lot of the activities already. So I hope we will join together again for next webinar. And thank you everyone for support us and giving an excellent and magnificent lecture today. Thank you. And have a safe of yourself, not to go anywhere that leads to get the COVID-19. Even though I think everybody already got the vaccination, but do not to be aware as we like all of you have a good health and we can come back together again. Thank you very much, everybody.
Thank you, Peter. Thank you very much, everyone.
Thank you very much.
Thank you, Mr. Kitano.
See you later.
again next time.
Yeah. Shall we have the
See
group
you.
photo?
Oh, please.
Good photo.
Yeah.
We
So
organize
I will capture the.
bring together in one page.
Yes. So everybody smile. 1, 2, 3. One more time, please. 1, 2, 3. Okay. Thank you.
Thank you so much.
Thank you.
Bye.
Thank you.
See you later.
Bye.
Recording stopped.